Platinum, we are just awaiting their accreditation, the Platinum Center for ECMO, which is a very big feat for anyone from India. And it is to the hard work done by Pranay as well as Dr. Venkat with Sunil Pubani and so many others, Vivek, Arpan, all of them walking in, and I'm sure they'll be joining us soon. But as we go about, it is also my proud privilege to say that AIMS started ECMO in 2002. From 2002, and it was a veno-arterial ECMO for pediatric cardiac surgery patients. And in 2002 to 2010, we saw a lot of mortality because of sepsis, because of bleeding, because of the kind of equipment that had yet not evolved. We were not using coated circuits. We were using roller pumps till about 2004-5, and then came the centrifugal pumps, better bioline coated circuitry, and everything improved. And in AIMS, we started the integrated ECMO. And the moment integrated ECMO started, today, as more than 1,000 cases of ECMO done, I don't know the exact number, but we've crossed 1463, I know that for sure. And our mortality stands at only 34%. So our timing may be wrong sometimes because we put it late, but wherever we've done integrated ECMO in our Al-Kappa patients, in our ventricular septum, D septum for switch surgeries, we've got excellent results. So keeping all that in mind and taking a cue from Dr. Sandeep Dr. Sandeep Chauhan, who is with us as the chief of the cardiac center and also as the head of cardiac anesthesia at AIMS. Dr. Neeti has joined us as chairperson for the first session. It's my proud privilege to introduce not just my department today to ECMO and the way we all do it here, everyone has to do it in whatever OT it is put. But I can say the leaders were tall, Dr. Venugopal and team thought ahead of times, and we stand tall today in India, at least as a pediatric veno-arterial center, and I'm sure soon to evolve as a eCPR center with so many cardio help machines that have come in. So over to Dr. Neeti to introduce our first speaker, our opening batsman, Dr. Muralidhar Kanchi. Dr. Neeti is the professor and in charge right now of the cardiac anesthesia. We are on a vacation here. She's just come back from a vacation. She has a lot of interest in academics, and she has paved the way for good academics in the department. I hand over the mic to her, and I request everyone in our department of cardiac anesthesia and critical care to join us today. Over to you, Neeti.
Thank you, Dr. Poonam, for the kind words. You are a very good orator. I congratulate you on all the occasions organized so many conferences. So now I introduce here Dr. Kanchi Muralidhar, who is an international figure and doesn't really need any introduction. I'm too small to introduce him rather. And he is academic director, professor, senior consultant of cardiac anesthesia and critical care at Narayana Health Institute in Bangalore. And he is the course director of transesophageal echocardiography workshops organized way back from last 15 years, I suppose. And he is a recipient of Rukmani Pandit Award. And a lot to say, a lot to add, but time is short. Over to Dr. Karthik Muridhar. He will be talking on physiology of ECMO.
Good
Physiology of
afternoon, everybody. Thank you for having me with you today. Can you please enable my screen sharing? My screen sharing is disabled. Can you please enable it?
Is it done, sir?
Yes, yes. Now it's done. I'm just sharing my screen. I think it has gone somewhere. Sorry, this is not the one. I'll have to do it again.
Sometimes like this, I wish we were all live together. Right? Yes, it's come. It's come,
It's
sir.
coming. It's
Yes,
coming.
it is. It is.
Now we are set.
Yes, sir. Please go ahead.
Thank you so much. In the next 20 minutes, I'll be dealing with the subject of physiology of extracorporeal life support. I would like to thank the organizers for this opportunity. And if there are any questions, please put it in the chat box. We will address them at the end. Basically, to begin with, the extracorporeal life support or the extracorporeal membrane oxygenation, as it is commonly called, is use of mechanical devices to support heart or lungs when they are failing, and the conventional optimal medical care has failed to salvage these patients. So managing these patients with when they are on these life support systems is substantially different from the conventional care, which requires a thorough understanding of the cardiopulmonary physiology, pathophysiology of the condition, and the ECMO physiology. In the next few minutes, I'll be dealing with the physiology and pathophysiology of oxygen delivery and consumption, which form the basic background for the ECMO physiology, and how the oxygen transfer and carbon dioxide clearance occurs in the membrane lung. What are the difference between CPB and ECMO, and also what are the difference between normal lung and the membrane lung, and a little bit about the circuitry used. Several lives have been saved each year worldwide because of the use of the ECMO, and this is a outstanding example of how a patient who was on life support system, including ECMO, for 14 weeks, survived without an inch of neurological damage. And when she met the father of ECMO, who is represented here on the right side, Dr. Bartlett, she knew no bounds of her enjoyment, and she is embracing her savior. If you look at the ELSO registry, the total number of cases cross about 130,000 with a success rate of about 1 minute. Success rate or the survival rate of about 55% in an aggregate. And if you look at the
संदीप मेरा ऑडियो ऑफ कर दो, इतने सारे ऑडियो का पैनल है.
if you look at the if you look at the number of ECMO centers, there are close to 450 centers all over the world, and North America leads the tally of figures. It has 261 centers, and in these 450 centers, I hope what Dr. Poonam Malhotra mentioned, that there were 21 centers in India are included, if they are already registered. This is the normal cardiopulmonary physiology, the oxygenated blood being pumped by the left ventricle, utilized by the tissues, and the deoxygenated blood coming back to the right heart, which is being pumped into the lungs for oxygenation. This is the normal physiology. What we need to understand when we talk about physiology is the oxygen content, which is probably the most important parameter when you talk about oxygenation in ECMO. Normally, in the clinical circumstances, we go by oxygen saturation and oxygen tension. But when we talk about ECMO, probably we should concentrate more on oxygen content, which is the amount of oxygen which is carried in the blood, which is a sum of oxygen which is in association with hemoglobin and the dissolved component of oxygen, which totals about 20 ml of oxygen for every 100 ml of oxygenated blood if the oxygen saturation is close to 100%. And the arteriovenous oxygen tension difference, or arteriovenous oxygen tension difference, is about 5 to 25 millimeters of mercury. But if you talk about the content difference, it is about 5 ml per every, which means that 20 ml is going to the tissues, 15 ml is coming back. So the arteriovenous content difference is about 5 ml. And we always have to refer to the oxygen dissociation curve, which is a relationship between the tension of oxygen in
इनको
the
कैसे बोला
horizontal
गया कि आप मत
axis
बोलो,
and the
ये
oxygen
10 मिनट
saturation in the
बोलेंगे,
vertical
इनको
axis.
मैसेज लिख
And
दो
this
काइंडली स्पीक
relationship is a
anticoagulation
sigmoid
for 10
relationship.
minutes.
And this is
हाँ
this understanding of
दूसरे
this
को
relationship is important
मैंने
when we
उनको बोल
talk
दिया था
about
नमन नहीं आ पा
right
रहा ना, तो
or
इसलिए
left
फिर
shift
10 मिनट
of the oxygen
बोलेंगे.
dissociation curve in
दूसरा
clinical scenarios.
दूसरा मुझे
And this
प्रोग्राम
is a
चाहिए,
summary
पता
of
नहीं
oxygen
कहाँ है वो देख रहा.
consumption when the patient or the individual has sepsis, fever,
संदीप
or
संदीप
has
संदीप
exerted himself or herself. The oxygen consumption increases. The normal oxygen consumption is about 250 ml
नड्डा से बात कर लो.
in a resting adult, which amounts about 120 to
उसका मिस
130
कॉल आ
ml
रहा है, ये
per minute
आ
per
नहीं पा
meter
रहा.
square in an adult person
इसके बाद क्या है,
during resting
उसी में
conditions.
है.
The other thing we need to know is that here we have represented the oxygen delivery in the horizontal axis and the oxygen consumption in the vertical axis. And what I would like to point out that there is a critical point of oxygen delivery. This is the oxygen delivery, and below which the shock state ensues. There is anaerobic metabolism, which is associated with increased lactate production and decreasing central venous oxygen saturation or mixed venous oxygen saturation. So this is the critical point, and we need to keep the patient above the critical point to avoid anaerobic metabolism. The other point I would like to highlight is that usually, as I already mentioned, we usually refer to oxygenation as PO2 and saturation. And what I would like to point out that is that oxygen content, which is directly related to the hemoglobin concentration, is very important in ECMO runs. And I think that estimating oxygen content must be given importance because here with the hemoglobin of 7.5 grams and 15 grams, if you look at the oxygen saturation is 100%, PO2 is 150, and you might think that patient is having good oxygenation, but the delivery may not be good because at a hemoglobin of 7.5, he or she is carrying only 10 grams percent of hemoglobin. Whereas at 15 grams of hemoglobin, the oxygen content is 20%. So, which means that hemoglobin, that is hematocrit, and oxygen content form an important component of assessment of patients who are on extracorporeal membrane oxygenation. The relationship between the oxygen delivery, which is shown on the horizontal axis, and the oxygen consumption on the vertical axis, normally is equal to 5:1, which means that if you are putting 1000 ml of oxygen into the tissues, about 750 ml of oxygen is coming back to the right side of the heart. It's about 250 ml is taken by the body in resting conditions. But if this ratio gradually comes down because of the disease process to about 2.1 or less than that, there is shock state and hypoxemia which ensues. Coming to the membrane lung, you have mostly we use the hollow fiber membrane where the gas is going inside the hollow fiber and the blood is coming onto the outer surface of the membrane. There is gas exchange taking place because of the tension difference between the oxygen in the oxygen carbon dioxide within the hollow fiber and the blood. The oxygen is going inside the blood and carbon dioxide is coming out of the blood into the gaseous portion of the oxygenator, and the venous flow which is coming to the oxygenator is getting oxygenated. The venous blood is getting oxygenated, and the outlet of the oxygenator is 100% oxygenated in most of the instances. We need to know what is the difference between the normal lung and the membrane lung. To tell you frankly, membrane lung is inferior to natural lung in comparison But when we want to tide over the crisis of respiratory failure, membrane lungs come very handy. The surface area of membrane lung is about only 5 meter squares, whereas the normal lung is anywhere beyond 55 meter squares. See at the enormity of the surface area provided by the respiratory epithelium in the normal human being. So only so much of reserve is there, but when the reserve fails, we land up with hypoxemia and respiratory failure. Basically, the ECMO, that is the extracorporeal membrane oxygenation, there are two varieties, veno-arterial and veno-venous. Veno-arterial is used for cardiac failure, whereas veno-venous primarily is used for respiratory failure. And we need to understand what is the concept of rated flow. The venous blood, when it is perfused through the membrane lung, when it exits the membrane lung, it is 100% saturated. But as the flow is increased, as the flow of blood through the membrane lung is increased, the outlet saturation starts to drop. The point at which it becomes 95% is the rated flow for that particular oxygenator. I will repeat this. As the venous blood is going through the oxygenator, initially at low flows, it is 100% oxygenated. The outlet oxygen saturation is 100%. But the moment it starts to fall and reaches 95, that flow will be the rated flow for that particular oxygenator. The indications for veno-arterial ECMO are mentioned here. Basically, it is cardiac failure with the cardiac index less than 2.2 liters per meter square, with a on one or two or more than two or more inotropes, and filling pressure of greater than 18 millimeters of mercury when you're talking about pulmonary artery occlusion pressure, and various causes of cardiac failure may be mentioned. And the amount of oxygen supplied by membrane lung is the flow times the inlet to outlet oxygen content difference. But when you talk about carbon dioxide removal, it is really a function of the sweep gas flow. Greater the sweep gas flow, the greater is the removal of carbon dioxide. What are the major differences between CPB and ECMO? These are mentioned here. Basically, one major difference is that in CPB, as conventionally used in cardiac surgery, the activated coagulation time is maintained beyond 480 milliseconds, 480 seconds, not milliseconds, 480 seconds. And in ECMO, we need a ACT of anywhere from 160 to 220 seconds. This is because of the fact that in ECMO, there are no reservoirs, and there's no stasis of blood. Coming to various types of ECMO, first depiction will be that of veno-arterial ECMO. This in babies, usually what we do for veno-arterial ECMO is in small infants, we have the drainage cannula in the internal jugular vein going through the pump, through the oxygenator, and the oxygenated blood is being pumped at the root of aorta through the common carotid artery on the right side. This is jugular carotid veno-arterial ECMO. In adults, what we do is we take out we insert the drainage cannula into the femoral vein. I'm talking about peripheral VA ECMO, drainage cannula in the femoral vein, and the venous blood is pumped back after oxygenation into the femoral artery. There are various combinations are available, which I will go through it in a succinct manner. This is the veno-arterial ECMO with jugular carotid access, which already we mentioned. The venous blood is taken out from the jugular cannula, pumped into the patient's arterial side after oxygenation. And this is the femoral axis. The venous blood is taken from the femoral vein. The tip of the cannula is at just below the junction of the RA and inferior vena cava. And then the blood is oxygenated and pumped onto the left side. And when we do that, if there is native heart functioning, some of the oxygenated blood which is pumped by the left ventricle may find its way into the upper story of the body. And if the lungs are not functioning properly, this blood will be relatively deoxygenated, and the patient's upper story will get relatively deoxygenated blood, leading to differential cyanosis, that the head is blue in color, whereas feet are red in color. This is called the north-south syndrome or the Harlequin syndrome, which can be tackled in one or three ways, which will be discussed when we talk about VV ECMO. The initial settings in VA ECMO are mentioned here. The circuit flow is about 2 liters per minute per meter square of body surface area. Usually is 2.4 liters. And the oxygen saturation in the outflow cannula, that is the return cannula, is about 100%. And in the drainage cannula, it's about 65%. Platelet count is maintained around 100,000 per cubic millimeter. And these are some of the indications which were mentioned in the Caesar trial. They went by the lung scoring, which is named after Murray, where they took the parameters, the 4 parameters: consolidation on chest radiograph, number of quadrants involved, what is the PEEP level used, what is the PaO2 to FiO2 ratio, what are the compliance. 4 parameters were taken, and if the severity score is greater than 2.5 or 3, the ECMO was initiated in the trial. Coming to the venous ECMO, the cannulation techniques, we can have a double lumen cannula. That is a single cannula which has 2 lumens. One lumen be placed just in the inferior vena cava with holes to remove venous blood from the IVC as well as the SVC, draining into the oxygenator, getting oxygenated, and being pumped into the other lumen in such a manner that the oxygenated blood is preferentially directed towards the tricuspid valve into the RV. If we do that, the lung function may be suboptimal. So we are already oxygenating the blood and giving to the right side, which will be pumped into the pulmonary arterial system and through the left atrium by the left ventricle into the aorta, which receives oxygenated blood as a result of venous ECMO. And there are 3 types of venous cannulations available. One is to have the drainage cannula in the IVC, as I said, about 3 centimeters beyond the IVC RA junction, the tip of the cannula. This is the femoral root. The blood is taken out. After oxygenation, it is put into the right atrium in such a manner that the blood is directed towards the tricuspid valve, taking care that the distance between the tip of the return cannula and the drainage cannula is greater than 10 centimeters to avoid recirculation. The second combination is that both the cannula may be in the femoral root, maybe on bilaterally you can cannulate, one for the drainage kept in the IVC, one for return kept in the right atrium. The other possibility is use a double lumen cannula, as I have already alluded to, and is the pictorial representation is mentioned on the right side of the screen. So you have oxygenated blood going to the tricuspid valve, to the right ventricle, into the pulmonary artery, the pulmonary circulation, then the left atrium, then the left ventricle, and into the aorta for systemic circulation. And we need to understand that there is a trade-off between hemoglobin and flows in extracorporeal life support system. Higher the hemoglobin, greater is the hemolysis. And hence, to have a balance between the flow and the hemoglobin, we need to maintain the hematocrit between 10 to 12 grams per deciliter in most of the ECMO, especially when it is venous and also vena arterial. About 10 grams is recommended, and the flow is maintained at about 4 liters, that is about 2.4 liters per square meter body surface area per minute. So this is the This is some of the X-ray pictures showing the veno arterial ECMO. Here we have a cannula in the right atrium. Most of them are central V ECMOs. What is shown here? Right atrial cannula, then the cannula in the ascending aorta, the chest is closed and this cannula are brought out by a small incision at the subxiphoid area. And in this case, the left ventricular vent is inserted to avoid left ventricular distension. Similarly, here there is a veno-arterial ECMO, the cannula is in the right atrium and the return cannula is in the ascending aorta. These patients can be extubated as is shown here. They may be mobilized and then they can be eating, talking, coughing, etc. To end the talk on physiology, ECMO is being utilized with increasing frequency to treat adults and pediatric patients and infants with cardiorespiratory failure who have failed conventional therapy. Successful initiation, maintenance, and weaning of ECMO requires a multidisciplinary team of physicians, perfusionists, nurses, pharmacists, physiotherapists, nutritionists, and other paraphernalia, other departmental support is also needed. And what I would like to underline is that ECMO is no longer an experimental therapy. It's an established therapy, established mode of support of patients with refractory cardiac or respiratory failure, with a hope that they will recover from the disease process, or it can serve as a bridge to transplantation or bridge to recovery. With this, I will conclude this bit of my talk. And if there are any questions, please put it on the chat box. And with the permission of the chair, shall I go to the second lesson, a second portion of my talk, or shall I wait for the second talk? Okay. Okay. I think I made a mistake. 1 minute. I'm sharing my screen again. I hope it works.
Yes, we can see.
Yeah, I'm just there. Thank you once again for the excellent opportunity. I have been asked to cover this topic in 10 minutes. I will be touching upon components of hemostasis. Basically, there are innumerable biological elements which are responsible for the maintenance of coagulation and thrombosis if there's damage to the vascular endothelium. The four components, major components are mentioned here. What are the coagulation factors? The platelet function, vascular endothelium, and fibrinolysis. If you look at the coagulation, it's a sine wave of activity as a result of tissue injury. There are four phases. I'll use the pointer. There are four phases. That is the initiation of clot formation, then acceleration, and then there is control, and then recanalization. These are the four components of the coagulation cascade. And this is the depiction of coagulation activation sequence. Is commonly taught in physiology. And we have the extrinsic and intrinsic pathways. And this is a mnemonic to remember the 13 factors. First person told cancer leads sickness. Another chap said protein, high fat. Each of the first letters of this represent the coagulation factors: fibrinogen, prothrombin, tissue thromboplastin, calcium, labile factor, accellerin, stable factor, antihemophilic factor, Christmas factor, Stewart-Prot factor, plasma thromboplastin antecedent, Hagman factor, and fibrin stabilizing factor. And what I would like to highlight in this slide is what are the factors which are dependent upon vitamin K, which are affected by warfarin therapy. These are factor 2, factor 9, factor 10, and factor 7. These are affected by vitamin K antagonists. And we have other direct thrombin antagonists and indirect thrombin antagonists. And the prime example of indirect thrombin activators, thrombin inhibitors, indirect thrombin inhibitors is heparin. And these are the methods to monitor the anticoagulation, the activated coagulation time, measurement of APTT, measurement of anti-10A levels, thromboelastography, ROTEM, and measurement of anti-thrombin 3 levels. These are some of the parameters which are used, and the advantages of each of the methods is mentioned on the right side of the slide. And the typical thromboelastographic tracing is depicted here. We have the R, K, MA, and lysis times, which are mentioned, and these are the signature graphs, whether the patient is having bleeding or thrombosis can be, or fibrinolysis can be made out at looking at the type of curve you get in the thrombotic, the TEG graph. And based on that, we can determine what is the therapeutic modality we are going to give, depending on the R, MA, and lysis time. Coming to heparin, heparin is derived from the pig intestine or bovine lung, and it was a result of the experiments conducted by a medical student. Please remember that a second-year medical student did discover heparin. We should give the credit to him. We are living because of him. We daily administer heparin to all our cardiac patients when they undergo cardiac surgery. This is the structural, brief structure about the heparin molecule. It has a molecular weight anywhere from 5,000 to 30,000 kilodaltons. Please remember that it's a heterogeneous molecule, and the pentasaccharide sequence, which is mentioned here in the green, dark green, is responsible for its anticoagulation effect as a result of antithrombin activity and as a result of anti-10 activity. So it acts by two mechanisms, that is by increasing the effects of antithrombin 3, that is enhancing the effect of antithrombin 3, and being anti-10A, it causes anticoagulation. And circulating heparin can be found on the endothelial cells or antithrombin heparin complex or in combination with anti-10A. And the problems with anticoagulation with heparin is heparin resistance, heparin rebound, heparin heterogeneity. That's why we need to monitor the heparin effects, and the decrease in antithrombin 3, and most important and potentially fatal complication is heparin-induced thrombocytopenia. I'll deal with it for a minute in the next few slides. There are two types, type 1 and type 2, and we are worried of the type 2 because there is severe thrombocytopenia, which is associated with deep venous thrombosis. These are white clots, and paradoxically, these patients, though they have thrombocytopenia, they will not bleed, and their typical manifestation is thrombosis. They can have CVA, they can have myocardial ischemia, myocardial infarction, they can have gut ischemia or limb ischemia. The proposed mechanism is that the heparin combines with platelet factor 4, and this, which is on the surface of the platelet, and this elicits antigen-antibody reaction, and the platelets are destroyed because of this. What are the alternatives to heparin in patients with heparin-induced thrombocytopenia? We usually go for direct thrombin inhibitors like bivalirudin. And these are the doses and the half-life, and how do you monitor them, and the special features of each of the direct thrombin inhibitors. I will just touch upon bivalirudin. The dose is about 1 milligram per kg bolus. In ECMO, we use lesser dose, and we give a infusion of 1 milligram per kg per hour infusion. And we can monitor ACT or APTT. And once you stop the bivalirudin, its effects are reversible automatically. There is no reversal agent, but because of the metabolism, it gets reversed by itself if you wait for 20 to 25 minutes. These are some of the papers which depict or support the use of bivalirudin, and safety and efficacy has been described in these studies. And if the patient has heparin-induced thrombocytopenia, which is documented laboratory by using serotonin assay, we have to change over to heparin alternatives. And we also can monitor the anti-10A levels. And as long as it is about 0.5 units per ml, it is perfectly all right. This is the laboratory schedule for monitoring the anticoagulation during ECMO, which has been highlighted in the ELSO guidelines. And what are the causes and treatment for bleeding during ECMO? The two major problems are bleeding and thrombosis. Both are dangerous, and you have to weigh both of them and see that ECMO run is safely conducted. And the etiologies are mentioned on the left side. On the right side, we have the management protocols. Depending upon the causative factors, either you determine the causative factor either using one of the viscoelastic tests and then come to the therapeutic goals. With this, I would like to thank you. And if there are questions, please feel free to share it on the chat box. And I think I've stopped sharing the screen. And thank you so much for this opportunity. Thank you very much.
It is my proud privilege. Due to paucity of times, we will reserve all the questions for tomorrow. And I thank the speaker as well as the chairperson wholeheartedly from TSS today. It is my proud privilege to invite Dr. Manoj Sahu, the head of cardiosurgical ICU at AIIMS, and he's heading it for the last 5 years, has done wonderful job in looking after many ECMO patients. We recently had a lung transplant, and Manoj and his team managed it all very well. So, Dr. Manoj, welcome to...
Yeah. Hello. Thank you, madam, for giving me the opportunity to be part of this program. This is a very excellent academic program for aspirants of ECMO. Now, I will be inviting Madam Poonam only to talk the next topic. Madam Poonam is, she doesn't need any introduction actually, because she is so popular. She is known everywhere in the circles of cardiac anesthesia and critical care. And she has been doing an outstanding job as far as teaching the academic programs, the simulation. She runs the Simulation Society. She was the founder, secretary, and chairman of the Simulation Society. And she has been delivering lectures all over the world. She has been a pioneer in conducting many conferences, workshops, and CMEs, which is very helpful for the students all over the country, not only in the country, but the Asia Pacific region. I do not want to take more time in introducing her. She will be talking. Thank you, madam. Please carry on with your lecture. We are eager to hear you.
Thank you so much, Dr. Manoj. It's nice to be working together and knowing each other's pluses and minuses. we all learn from each other, and that's what I feel is the boon of a department like AIMS. Echo in ECMO came up in a, Echo in ECMO is my lecture today, and Echo in ECMO came up in a very, very big way. I think they've on the wrong lecture. That was supposed to be Dr. Mullidhar doing it. Can we do Echo in ECMO, please? Can we do Echo in ECMO, please? Yeah, so we had a drop in one of the things. I'm sorry for this goof up for a small time. Echo in ECMO came up in a very big way in the late 2014-15 when imaging the ECMO cannulas, imaging the guide wires, which were not so radio opaque at that time or radio translucent, the transparency could not be seen, and seeing everything, fluoroscopy was the only hope left. Then came ultrasound, and then transthoracic echo was of course there, but no one thought of using echo for ECMO till a lot of ventricular assist devices as well as a lot of other substances such as ultrasound bedside, POCUS, FATE, FEEL, etc. came up. Now, while we were on this, doing echo for ECMO became a very, very big plus for us, because you knew which patient to select for ECMO, you knew which patient to cannulate and how to cannulate and maintain the cannulas. You knew how to monitor the ECMO, because monitoring during ECMO may see cannula migration, monitoring during ECMO may see any venous cast or oozing around the cannulas. It may also see any kind of thrombus around the cannulas. When things like this were happening, it was very, very essential that we monitor with echo. So I always insist that when we buy an ECMO machine, we request the administrators of the institution to buy an echo machine and a rotum or a sonoclot or a TEG machine, because just as bleeding on ECMO is very, very pertinent, so is doing echo to maintain and monitor your ECMO. And also, after you know that there is no cast, there is no thrombosis, your LV is not distending, your mitral regurgitation is not worsening, and the right side of the heart is showing good RV function, we can decannulate the ECMO by having first a trial off and then a weaning. So when we are particularly doing such major steps on ECMO and we want to select our patients well, then it is important to rule out certain biological conditions in the patient. Let's say a patient has a Chiari network in the RA. Now, if you put in a right-sided dual lumen cannula or a right-sided into the RA, a single lumen cannula, which is going to be a drainage cannula, which is going to outflow and give a good patient's drainage into the ECMO machine, then a Chiari network which is present at the inset is going to cause obstruction to the cannula. And when things like this happen, it is important, whether it is a VV or a VA ECMO, to go ahead and see that there is no PFO, there is no ASD, and there are a few views which I will be briefly touching upon because of some glitch there again in the technical circuit, but trying to see what are the major 5 views. Well, you have the mid-esophageal 4-chamber view, which tells you a good things about the LA, the RA, the LV and the RV with the septum of the IAS, the atrial as well as the ventricle seen very well. When you see any VSD or you see particularly any ASD, you know that your cannula may go from the RA into the LA and then into the LV. What will it cause? It will cause a right to left shunt. And when it causes a right to left shunt, a patient who was acyanotic would slowly become cyanotic. And when something like this is happening, it is wise and it is good at that time to go on the pump drainage system being slowed down and seeing the echo in detail. And once we see the echo and rule out, yes.
Poonam, really sorry. Can you share your screen, please? We're not seeing the screen.
Yes, it is coming. It is coming. I'm just waiting for the screen to come. There's a small technical glitch for another 30 seconds. We are on a new system with the YouTube, so YouTube takes some time in between. So it's coming.
Thank you.
It's coming. So when you see the RA to LA to LV cannula migration and you want to rule out the cyanotics not being present, then you want to know that nothing is amiss with the cannulations and the cannula. And when you are seeing something like that happen, it is wise at that time to change your cannulas or to pull up your cannulas and to correct the positioning and put another cannula. If we were on a VA ECMO, we can be on a VAV ECMO at that time. So when something like a wrong cannula, like a RA malformation of Chiari network, PFO, ASD, cannula migrations is to be seen, let us know for certain with an echo that something known as echo on ECMO is essential. I think I will come back to my talk because there is, yeah, we are there. So ECMO is a rescue therapy, and if it is a rescue therapy, can I have the next slides, please? Next, please. We know whether we are on VV or VA, with Dr. Robert Bartlett paving the way to forming echo and ECMO as a more important part, we must know where not to use the ECMO, and that is in a patient of aortic dissection, that is on a patient with any kind of severe AR. This is a Chiari network, and if you see the Chiari network, the interatrial septum would be seen very nicely. Can we go on to the next one, please? Yes. So interatrial septal aneurysm is another aneurysmal position where cannula may migrate. And when you see things like this happening, you know for certain that your patient will have a PFO, or your patient will have an IAS which is aneurysmal and not work at all. So an ASD, a PFO is a big no-no, as I was saying. The severe pulmonary artery hypertension, the cardiac failure, we always want to consider VA ECMO. How do we insert the cannulas and place the cannulas well is again a big thing that echo can teach us. And when we see this, let's see this position. Now here you can see both the guide wires. If I show you here, that's the guide wire there. You can see the guide wire. This is the interatrial septum above. And when you have the interatrial septum above and you see the bicable position, you correlate it with the X-ray. You see the access cannula above in the left common femoral vein, and you see the right coronary femoral artery below. When you are seeing the position of the access and the return cannula on an X-ray, you are convinced that the cannulas are in position and I don't have to do anything more. When things like this are to be seen, rule out the position of the coronary sinus. Sometimes it may be very big, you may have an LSVC. Rule out the movement of a cannula across the tricuspid valve or through the patent foramen ovale, and always see the Avalon dual lumen cannula, one lumen in the deoxygenated blood to drain from the IVC and the SVC, and the second lumen allows the deoxygenated blood to return directed towards the tricuspid valve. So as you can see here, the cannula is directed towards the tricuspid valve. This small cannulation technique, if well seen on X-ray, as to how far off is the cannula from the RA mid cavity and the position of the tricuspid valve, then we will, on a VV ECMO especially, avoid recirculation, because it is proximity of the two cannulas, the access and the return very close to each other, that brings about the recirculation, which leads finally to the north-south syndrome, which we will discuss in a short while from now. So venous cannula should be positioned always in the mid-right atrium to allow optimal blood flow into the circuit. The peripheral arterial cannula cannot be visualized, and imaging of the guide wire in the ascending aorta can prevent malpositioning of the cannula. So you can see here, that is the ascending aorta in a VA ECMO, and you can see that the cannula is very well positioned on a VA ECMO. Now, most of these cannulas, when you see the cannula appearances, are serrated. So you can see the serrated of the drainage cannulas, most of them, and cannulas on VA ECMO will also show any distension of the LV. So that's a cannula position at long axis view where the LV seems to be distended. So the return cannula should be in the mid right atrium and the access cannula tip should be in the proximal IVC. Now, echo is essential to check the position of the cannulas in all these positions, but also to avoid any myocardial injury, because myocardial injury would lead to any kind of intraoperative or intra-ECMO ischemia. Monitoring during support should see the underlying LV dysfunction, look out for pulmonary congestion and edema, blood stagnation in the LV, distension of the LV, worsening of the mitral regurgitation, worsening of the tricuspid, and non-closure of the aortic valve. And when you see non-closure of the aortic valve, as you see in this M-mode echo, which is taken across the aortic valve here in a 4-chamber view, you can visualize the thrombus in the LV, and this thrombus is not allowing the aortic valve to open at all. And you can see the LV distended. This is a LV that needs to be unloaded. So whether you use a balloon atrial septostomy, or you use an LV vent, or you do retrograde LV unloading or inotropes and vasodilators, or use an IABP, this LV thrombus with LV distension is not going to let your ECMO work. So monitoring the ECMO to prevent LV thrombosis, which may go on to the ascending aorta and close the aortic valve because there will be no output, is again decreasing the ECMO drainage. So a 2-year female with fulminant myocarditis on a bridge 2 recovery with a VA ECMO did very well because an echo was being done in this patient. However, sometimes we may have in another patient a lot of liver congestion, patient may be in PH, and this is a hypertrophic cardiomyopathy. Here the liver is congested, you can see the IVC is dilated beyond 2 centimeters. You see the hepatic vein is sinusoidal, and when you do a before ECMO and an after ECMO, you can see the pulse venous Doppler of increased systolic and decreased diastolic being taken care of while on ECMO in this patient of PAH. So increase mixed venous saturation, decrease the PVR, decrease the RV afterload, and increase the ejection fraction of the LV is what is important when we do an echo in an ECMO patient. The other, as I said, was to detect the complications. Now, complications could be because of circuit, cannulas, bleeding. It could be due to heat exchangers. So many times patient may not rewarm. So many times there may be a bladder disruption. There would be thrombosis in the LV. You can see the interventricular thrombosis, which may give rise to subendocardial ischemia. And ECMO and LV akinesis can increase this risk. When you have things like this happening and you are seeing, can I have the next one please? When you are seeing, I'm sorry, my videos are not working, but when you see thrombosis in many parts of the ascending aorta, or you are seeing these in any part of the LV, then you know for sure that liver splanchnic organs congestion, SVC syndrome, reduced cerebral perfusions are in, and flow obstruction to these cannulas will happen, especially the IVC cannulas, sometimes even the SVC cannulas. When you see flow obstruction in the venous cannula, then you know your ECMO flow is going to be decreased, and Dr. Muralidhar just showed how the ECMO flows was decreased. When you have a patient with Beck's triad, where we see post-cardiac surgery, a lot of pericardial tamponade and a cardiac tamponade with fluid around the LV and the RV, and raised JVP with pH, and sometimes decreased absolutely dull venous vasculature, then you must rule out a bleeding tamponade, and a bleeding tamponade would show up as we saw in this stuck DVR, which came for a repeat redo DVR, and we could not come off, and we put in an ECMO in such a patient. So I would like to end here because my videos are not working, but I would like to say that it is with the leaders that we are born. This is the 2018 SWAC-ELSO conference at Delhi in India Habitat Center. I invite you again as the president of SWAC-ELSO to the next round of SWAC-ELSO conference at Ludhiana, Dayanand Medical College in February next year. Under the auspices of the ECMO Society of India, with SWAC-ELSO, we stand tall from India. And yes, Dr. Muralidhar, we are 21, about to be 25 centers from India here. Thank you so much. Can we have the next set of chairperson with us? Dr. Vivek Gupta is our next chairperson. Can we have the next one, Sandeep? What is happening? Our next speaker for the day is Dr. Pranay Oja, a man who doesn't require much introduction. I call him the flying ECMO intensivist of the country. I hope I'm audible to all.
Yes, madam, you are audible.
Yes. So while we see it and we are just on the audio, it's my proud privilege to invite Dr. Vivek Gupta to talk, I'll only chair this with Dr. Pranay Oja. I would like to introduce him as the flying ECMO intensivist of the country. He has moved by leaps and bounds in doing ECMO all throughout all centers, starting with the RVCC, one single hospital in Mallar. I was in Alasupara with all of them, the ECMO Society of India, and I saw how great the following of the fellows is to learn ECMO from this DO of Dr. Venkat Goel and Dr. Pranay Oja. Dr. Pranay Oja is the secretary of SWAC also for the past 5 years. His academia and his manuals are very well known. Very soon to come out with a book on ECMO, Dr. Pranay Oja today would be talking to us all about veno-venous ECMO. So COVID showed us the way that veno-venous ECMO is the need of the hour, and that is why the interest in ECMO grew. Whether it was dengue, hemorrhagic fever, or it was COVID, or it was the Hini influenza, or it was the Caesar trial after the Hini influenza, we know ECMO is here to stay. And what better veno-venous ECMO for ARDS than from Dr. Pranay Oja. Over to Dr. Oja, please.
Thank you, madam, for your kind introduction and giving me an opportunity to speak. Okay, so all about VV ECMO is a huge topic. I'll try to finish in 25 minutes. So basically, it's a ECMO where we drain the blood from the vein and return back into the venous side. Either to the same vein, that is what we call as a single site, or with the help of double lumen catheter, or in a different vein where we selected two sites and there are two catheters placed, one in the femoral and one in the jugular, or both in the femorals in two different ways. And this is primarily be done for the support of respiratory system or for the lung support. So what are the advantages of VV ECMO is the pulmonary flow is maintained and it reduces the ischemic lung injury it increases the PO2 to the pulmonary bed, so that by it helps the lungs to heal fast. It leads to pulmonary dilatation, which in turn leads to decreased pulmonary vascular resistance, decreased pulmonary hypertension, reduce the septal displacement, and it improves the LV function indirectly. Oxygenated blood goes to the coronaries, and again thereby it increases the myocardial oxygen supply, and thereby it improves the cardiac function. And loading condition of the heart remains unchanged. The CEP and pulse is usually not get affected. So if you see the physiology of VV ECMO is usually in series to the heart and lung. It does not bypasses the heart and lung, but it remains in the series in the heart and lung. So there is a dual circulation that occurs. We will talk on VV oxygenation and then recirculation. So dual circulation here, VV oxygenated blood goes to the pulmonary circulation and then it gets mixed there, and then it goes to the systemic circulation. And here, because the systemic circulation is in the series, so there is no effect on systemic circulation to a great extent. Okay, no direct effect on systemic circulation, but indirectly it improves the blood pressure by improving the cardiac contractility because of the increased, as I told you, myocardial oxygenation, correction of the metabolic factors like respiratory acidosis, hypoxia. So thereby it increases the blood pressure and it reduces the high ventilator settings and thereby decreases the intrathoracic pressures, and thereby it can improve the blood pressures. So this I just talked about. So the advantage is it's going to be, it preserves the pulsatility, it avoids the congestion of major artery, it is minimally invasive, it reduces the neurological complications, it decreases the chance of systemic embolization and blood entering the cerebral circulations under the low pressure, and that does not cause cerebral pre-perfusion injury. But the disadvantage is it cannot give you cardiac support. So in case of cardiac arrest, so in case of arrhythmias, so in case of myocardial failure, this VV ECMO is not useful. Oxygen level remains relatively less, but oxygen delivery is usually okay. So you don't get the PO2 around more than 100, or you don't get the saturation 100 immediately when you put the patient on VV ECMO. It slowly stabilizes the patient. Recirculation chances are high, so you might require to put an additional drainage cannula, and ECMO blood flow rates usually increase by 20% because of to overcome this recirculation. So in VA ECMO, when we calculate how much flow patient might require, we usually calculate around 100 ml per kg. But here usually in VV ECMO we calculate around 120 to 150 ml per kg is the flow requirement. So what are the types of VV ECMO? Types of VV ECMO, there are variants of VV ECMO as well as there are hybrid modes of VV ECMO. Variants of the VV ECMO is here it remains the mode of ECMO remains the same VV ECMO, but it changes the vascular access or the equipment. So if you require an additional drainage cannula, it becomes VV ECMO, or it is ECCO2R removal where it is just take care of the carbon dioxide removal. Okay, so that can be a arteriovenous CO2 removal device or a PECLA, or it can be a VV ECMO ECCO2R. While it can be a hybrid mode where you require an additional support of the heart, and then it becomes a VVA or VVBA. So in VVV, we require an additional drainage cannula, okay, but the mode is going to remain the same. That is for the only long support, and this you require for two conditions. One, you put an additional drainage cannula. See, these are the two drainage cannula, and this is one return cannula. Here, the two drainage cannula is required. First, if the drainage is not adequate, or second, there is a high risk of occlusion, so you might require to put additional drainage cannula. While VVA ECMO is where the patient requires additional return to the heart because there is a cardiac failure. This is occurred usually for the right ventricular failure during the patient on ECMO, VV ECMO, because of severe pH. So it's notified to this type of ECMO. During the run, it can become, if the cardiac failure occurs or severe right heart failure or pulmonary hypertension occurs, then you have to convert into VVA ECMO, where you have to add additional arterial cannula. If your drainage is an issue, you might have to put an additional drainage cannula. It becomes VVV ECMO. Or you just want to get rid of CO2, then you have to put ACCO2R, and that is just removing the carbon dioxide. Based on the configuration, it can be VPA. Here the drainage is in femoral vein and IJV, while return is going to be in a pulmonary artery. This is for a right heart failure. VVLA. Here, one drainage, femoral vein, and two return. One goes to the IJV and one goes to the left atria. Again, that is for a refractory hypoxia or when there is a right heart failure or pulmonary hypertension. Or it can be a veno-venous ECMO where there are only two cannulas, but you do atrial septostomy. Again, that is just for a refractory hypoxia. Now, if you go to statistics, around 172,000 cases has been registered so far, with almost around 68% success and survival to discharge around 55% overall. And if you see, the maximum number of patients has been done is in the adult respiratory failure, okay, with a 66% survival and 58% survival here. And if you see last 5 years record from 2007 to 22, the maximum number of cases have been done again adult respiratory ECMOs. So if adult respiratory ECMOs are the ones which are picked up later on, but that has gone up like anything, and the survival rate remains still around 58 to 60% survival to discharge. And most of these respiratory ECMOs have been supported with almost around 95% of the cases have been supported with the VVA ECMO. Some only few patients might require a hybrid mode like VVA or VA ECMO. Okay. While in case of adults, while in case of neonates, because the vascular cannula availability is an issue, that's why most of the ECMO, still respiratory ECMO becomes VA ECMO, and very few are going to be VVA ECMO. And this is the graph you see from 1987, how the number of cases of VA ECMOs, adult respiratory ECMOs keep on increasing. What are the indications for VV ECMO? Indications can be for acute respiratory failure or can be chronic respiratory failure. So it can be bridge to recovery, where there is a reversible disease which is not responsive to your conventional therapy, or in case of chronic lung disease, when there is an acute exacerbation and you require to put the patient on ECMO. It can be for a bridge to transplant, for a chronic cases where there is an acute deterioration, patient who is waiting for the transplant list, and then it can be bridge to transplant. So it can be used both for oxygen failure as well as for the ventilatory failure. So it can be used for hypoxic respiratory failure due to any cause like ARDS, pneumonia, polytrauma with lung confusion, inhalation injury, poisoning, or acute exhaustion of chronic lung disease like ILD, cystic fibrosis, or even for the post-transplant like primary graft dysfunction or rejection. Or it can be because of the CO2 retention on mechanical ventilations like in case of COPD or status systematicus, or in case of severe air leak syndrome, any patient on ventilator developing barotrauma. What are the contraindications? If you ask as for the ELSO guidelines, absolute contraindication is usually nil. It depends on how the patient respects to the risk and benefits to the patient. Okay, but relative contraindications are associated. Those which are associated with the poor outcome, they are considered as relative contraindications. So, patient on mechanical ventilation support for more than 7 to 10 days, they are not considered for ECMO because the outcome is not going to be good. Major on pharmacological immunosuppression, CNS hemorrhage, non-recoverable or comorbidity, underlying comorbidity, and present in a gross multi-organ failure. These are all relative contraindications where things may not help to a great extent. For a traumatic patient, again, there is a relative contraindication. Usually for traumatic brain injury, we try to avoid for 24 to 48 hours if possible, because just to decrease the risk of bleed in the brain. Actively bleeding patients and which is non-compressible, and when we are contemplating the surgical interventions, you try to avoid ECMO for 24 to 48 hours if possible, again, if the patient condition permits you. Okay. And when we analyze our data in 2017-2018, what we found is the H1N1 and non-H1N1 cases are almost similar in numbers, and the survival rate was almost the same. But what is more important in this is those who non-H1N1 with leptospirosis, dengue, malaria, they have much better survival, almost around 60% survival as compared to other cause of other cause which requires ECMO support. Another finding which we found most important and interesting is the average ECMO run in case of patient with H1N1 is much higher as compared to the average ECMO run in a non-H1 patient. Non-H1N1 patient remains around 9 to 10 days on ECMO on an average, while the H1N1 patient requires almost around 19 days to be on ECMO. So that is a major significant difference between the two group of patients. So when you think patients should be considered for ECMO, you look at a PF ratio, you look at a PCO2, you look at a pH levels. So the inclusion criteria remains when you try your best for a medical resuscitation in terms of using the different modes of ventilator, proning and everything. And in spite of that, the condition does not improve in next 4 to 6 hours time, then you should think of patient to be put on ECMO. So if the PF is less than 100 or oxygen index more than 30 or Murray score more than 3, these are the common conditions where you need to put the patient on ECMO, or patient with hypercapnia with a pH of less than 7.2 observed over more than 3 hours. With your all-based resuscitative modes, that does not help. So in our study, we found that those who have put on ECMO for PF ratio of more than 75, they have much better outcome as compared to those who have been put on ECMO with PF ratio less than 50. Similarly, those who has gone into hypercapnia with the PCO2 level going high, and when you initiate ECMO when the PCO2 level is high, the survival chances goes down as compared to when the patient be put on ECMO with the PCO2 still on in a normal range. The survival is almost around 59 or 60% here as compared to the survival which is around 30 to 35%. Okay. So this was our observation is when the ECMO is initiated within 7 days of ventilator, the outcome was better as compared to initiated after 7 days. Respiratory failure with high CO2 has a poor outcome, and those with obese patient has a poor outcome as compared to that. And in ECMO initiated with the PF ratio of more than 75 has better outcome as compared to when they have been, you still wait and let the lungs to worsen and then you initiate ECMO. So early initiation is going to be helpful. What are the exclusion criteria? You can't use VV ECMO for ECPR or for a cardiac support, or with a patient with septic shock with an inotropic score more than 100. VV ECMO may not be sufficient alone. Remember, inotropic score is not a contraindication for an ECMO. So even mild to moderate inotropic score you can use VV ECMO, and there definitely it helps. Okay. For respiratory failure, such as myocardial failure following the cardiac surgery, again VV ECMO may not be the good. Or when you have a vascular access issues, you don't have a good vascular access, again then the VV ECMO should not be think of, and then in that case you have to go for a VA. So, as I told you, the inotropic support is not a contraindication of VV ECMO. So, when we put the patient on VV ECMO, many times the inotropic score decreases, the patient hemodynamic improves, BP improves. And the reason, as I told you before, is because it improves the cardiac contractility, because it improves myocardial oxygenation, it corrects the metabolic factors, and your ventilator requirement comes down, thereby decreasing transthoracic pressure, and thereby it improves the blood pressure. Now, management of patient on VV ECMO. So first, when we discuss on management, what is the purpose of VV ECMO? That depends, the management depends on that. Whether we are using ECMO for a rescue therapy, or whether we are using ECMO as a lung rest, or whether we are using ECMO as a bridge to transplant, or as a transient for the procedural support. It depends on that, the management will vary with that. If you are so what's your goal for the patient to be put on ECMO? There are two goals. One is give adequate and safe support to keep the patient alive. That's the first goal. And the second and the most important is give rest to the lungs and prevent ongoing damage to the lungs. And then by this, we try to speed up the lung recovery. So management of VV ECMO depends on, basically it includes three components. One is the management of ECMO, that is the adequate and safe support. So you have to maintain the blood gases, manage the anticoagulation, avoid complications, recirculation and infection. Management of the lungs, it be basically you think of ventilator management, and then by help the lungs to recover fast, and the general management of the patient in case of other organ functions and nursing care. So what are the ECMO goals to achieve? You might try to maintain the hemoglobin saturation of more than 85, hemoglobin around 9 to 10, venous saturation around 70, PCO2 less than 40, try to maintain the pH normal, and mean arterial pressure more than 70. That does not mean that if you have saturation of 70, you always have to act it. You try to accept an even lower saturation if the patient is awake and he is maintaining hemodynamic. And then the rest of the general management of anticoagulation, ventilator, hemodynamic management that I'm going to discuss in future slides. So, what are the blood gas managements? First is you try to maintain adequate blood gas. You try to maintain PO2 of more than 50, saturation more than 85. CO2 depends on what is the baseline CO2, because if the CO2 is baseline is very high, 110 or more than 100, then you have to get the CO2 down gradually. So that I'll not say the figure, but then it has to be get down gradually, and depends on try to maintain the normal pH. What is acceptable blood gases is a PO2 of more than 40 is also acceptable at a time. Saturation of around 70 to 75 is also acceptable. But for that, you have to observe the patient for his sensorium, for his hemodynamics, urine output, lactates. If all these are fine, then you can even accept the PO2 from 40 to 45 also. Okay. But suppose your sensorium is going down, or hemodynamics are not maintained, or lactates are going up, then you think that PO2 requires to be treated. And then how will you treat this PO2? By increasing the ECMO settings, by increasing the flow or ECMO FiO2, by increasing the oxygen delivery to the tissue, that you can do by increasing the hemoglobin level, by decreasing the requirement, so you can decrease the metabolic rate or decrease, cause hypothermia, that can decrease the oxygen requirement. And the last what we'll do is usually is to increase the ventilator settings only when the ECMO has some issues. Otherwise, you usually don't prefer to go up on the ventilator settings. Okay. And how will you treat the PCO2? By increasing the sweep gas. What is more important? What is the underlying cause which causes the blood gas management issues, hypoxia or hypercapnia, and try to treat that. So as I told you, CO2 can be managed with the help of sweep gas, and PO2 can be managed with the help of flow and FiO2. So management of oxygenation is maximize the gas transfer, minimize the oxygen utilization, and decrease the recirculation. Maximize the gas transfer by maximizing the blood flow through the system. So you put adequate size cannula, increasing the FiO2 of ECMO, or increasing the hematocrit. How will you minimize oxygen utilization? By decreasing the metabolic rate, by controlling fever or any other factors, patient is anxious, so sedate the patient, or by causing hypothermia and decrease the recirculation in a VV ECMO. So how will you maximize the blood flow through the system? Is by using an appropriate size drainage cannula. So put a larger size drainage cannula, place it properly so that you get a good flow. If required, you put an additional drainage cannula, and by increasing the FiO2 in ECMO and by increasing the hematocrit. So whenever you try to increase the hematocrit, definitely the saturation, it increases the venous saturation, it increases the PO2 level. So in those patients whose hemoglobin, whose saturation remains lower than 80%, you tend to increase the hematocrit and thereby you try to maintain the oxygen delivery. How will you minimize oxygenation? By decreasing the metabolic rate. So if it causes hypothermia, it is very well known that the moment you decrease the temperature from 37 to 34 degrees, your heart rate decreases, your cardiac output decreases, and your oxygen saturation automatically improves because your demand decreases. So hypothermia can improve the oxygen saturation. But the problem is that with hypothermia, it will increase the risk of infection, immunosuppression, arrhythmias, it can cause coagulopathies, and even the drug metabolism is altered. So we don't usually do hypothermia. Okay. Whenever the cardiac output increases, it increases the venous saturation, definitely. But in case of VV ECMO, what happens is there is a dilutional effect. So your ECMO flow is around 4 liters, and if your cardiac output is 6 liters, you are almost 2/3 of the blood you are oxygenating. But suppose your cardiac output increases from 6 liters to 10 liters, and your ECMO flow remains 4 liters, you are not even oxygenating the half the cardiac output. So in that case, increase in the cardiac output will cause decrease in the oxygenation. So when patient is on VV ECMO, anything which increase the cardiac output will decrease the oxygenation, and thereby patient becomes anxious, sedated, fever, or anything which increase the metabolic activity, or patient goes into sepsis, the saturation decreases. So one of the way of getting the saturation improved is by use of esmolol. So patient with a high dynamic, hyperdynamic circulations and hemodynamically stable, then you can use esmolol to get the heart rate down and thereby to get the saturation up, because you have, in that case, your cardiac output and blood flow ratio improves, and thereby you can improve the oxygenation. If whatever you do, if nothing helps, the last choice is to convert VV ECMO into a VA ECMO. So when you require circulatory support, when there's a refractory hypoxia, or when there's a right heart dilatation occurs, you might think of switch over to VA ECMO. Now, what are the complications related to VV ECMO is recirculation and pulmonary hemorrhage. So recirculation of blood which is returned, the blood which goes through return cannula, same blood comes back to the drainage cannula. That is what we call as recirculation. And this occurs, on average recirculation around 30%. And this occurs because both the cannulas are in the venous system only. And if this cannula are more close to each other, then the chances of recirculation keeps on increases. So decreasing the venous saturation will, the SpO2 will decrease, while the increasing the pre-membrane saturation will increase. That suggests you of recirculation. So this is what the drainage blood, same drainage blood goes back to the return blood goes back to the drainage system. That is what recirculation is. So recirculation can be because of cannula position. How will you detect? By seeing the cannula position, by the visual inspection, and by thrombodylatation technique. So you can see here both the tube colors, the one return cannula and the IVC drainage tube colors are same. So this is what a recirculation is. While SVC color is different. So there is no recirculation in SVC but drainage cannula. But in the IVC drainage and in the return cannula, both the colors are same. So that means it is a recirculation occurring there. Okay. You can see here there is no recirculation here. Both the colors are, the drainage cannula and return cannula color are quite different. And here you can see there is a recirculation because both the colors have become more or less the same, and the both are bright color. Okay. So there is a way of calculating the recirculation. The pre-oxidant saturation minus the venous saturation, and the post-oxidant saturation minus the venous saturation. The average of that is your recirculation. If you calculate 30% of recirculation is acceptable, but more than 30% recirculation is not acceptable, and you have to do something. Okay. Now, what are the factors which affects the recirculation? One is the pump flow, second is the catheter position, third is your cardiac output, and fourth is your right atrial size or intravascular volume. So if you see the graph here, when the flow increases, okay, as the flow increases, the effective flow increases first, and then it becomes almost standstill, and then it starts going down. Okay, this is what the effective flow is usually, while your recirculation flow is usually a linear graph. So as the pump flow increases, the recirculation will keep on increasing, and at one particular point, the effective flow will not. So even if you increase the pump flow above and over it, the saturation won't improve, but on the contrary, the saturation will start going down, and that is what is known as the defining a curve. So this is what the increased flow, too much of high flow, if you keep, can give us to recirculation. So what you have to do is, when you see a recirculation, you have to wean the pump flow. You have to decrease the pump flow. Say if your pump flow is 4 liters, you make it 3.7 liters and see what happens. If the saturation improves with that, it means that it was a recirculation which was because of the pump flow. If you further come down to 3.5 and the saturation remains same or it goes down, that means that is at least that is the flow which patients do require for that. So you have to always define the curve when you put the patient on VV ECMO to rule out whenever you see recirculation, when the patient on VV ECMO. Second, the commonest thing which is there is the catheter position. If the catheter cannulas are too close to each other, then it can give us to recirculation, and you can diagnose with the help of X-ray chest or with the help of Doppler. You can see the cannula position. If they are too close to each other, then it can give us to recirculation. Second chance of recirculation is more when you try to drain from RJV and return to IVC, the recirculation chance is more as compared to when you drain from the IVC and return back to the IJV or SVC. Double lumen cannula, if it is not properly placed, the recirculation risk will increase. Another factor on which the recirculation depends is the cardiac output and the right atrial size. If the heart stops completely, there is always 100% recirculation, because there is no point where the blood can be, your valve opens, and because the valve does not open, it can give us to the 100% recirculation will occur. And that's the reason when the patient of VV ECMO goes in cardiac arrest, you have to give a good cardiac massage. Second thing, whenever the intravascular volume is less, when the RA is empty, again, whatever the return cannula blood comes, that all goes to the drainage canal because RA is not full. So you have to give probably volume expanders and blood to counteract this for a recirculation. Again, if the cardiac output is if the heart rate is too high, there is no sufficient time for the valve to open, and that's the reason the recirculation can increase. So whenever there is an arrhythmia or whenever there is a hypovolemia, all that can lead to recirculation. So what is the treatment for recirculation? First is you have to see the position of the cannula and make the appropriate distance. Second thing is try to find out a cause and treat the cause. And if you find that whatever you do, nothing helps, then you have to put an additional drainage cannula, and that will counteract the recirculation. And when you put an additional drainage cannula, what you usually do is the right femoral cannula, we put it as a return cannula and goes up to right atrium, while your SVC, the IJV cannula, and your another femoral cannula that is from the IVC, though both will be act as a drainage cannula. So your right IJV drainage cannula, your left femoral drainage cannula, and return cannula is in the right femoral vein going up to the right atria, and this will decrease the recirculation to a great extent. The best way of getting the recirculation down is by using a cephalate cannula. Again, none of us are doing the cephalate cannulation, so but that is more for theoretical. But it helps in decreasing the recirculation. It increases the amount of oxygen added per pass, and it continuously measures the cerebral saturation also. And as I told you, the last system is going to be converted to VA. So what should be the ventilator management when the patient is on VV ECMO? Yes, just 2 minutes. So usually we use a rest ventilator setting with a pressure control mode and respiratory rate around 10 to 12, and we keep the peak pressures less than 25, PEEP of 12 and FR to 21. In pulmonary hemorrhage, we try to go for an APRE mode, so give hemostatic effect. And in case of air leak syndrome, we try to keep the peak pressures less than 20 and titrate the peak from 0 to 6. And then try to keep them peak pressure support. What is more important is give the prone position to the patient. That is again more important. Okay. So when we initiate a patient on ECMO with a white out lung, tidal volume less than 2 ml per kg, we think of proning the patient. And later on, when the patient improves with some blackening on the X-rays and with the tidal volume little improved, when patient tolerating the ventilator settings and try to remain awake, then we try to keep them awake. Okay. Physiotherapy is again an important thing. Active mobilization, keep the patient awake, make the family to talk to the family. This is important. Anticoagulation management, ACT we try to keep around 160 to 180 with the 20 units per kg per hour of heparin. Hemodynamic management is going to be as usual. Initially, there might be hypertension, but then that is supported with noradrenaline. But usually, they go into hypertensive response and they respond to lobetalol, anti-G or nitroglyceride. Okay. Fluid management depends upon how much the flow is. Initial 48 hours, you might require good fluid management. What is more important is your pre-pump pressures. If it is too negative, you need to give more fluids. Okay. Transfusion, hemoglobin, accept up to 8. If there's no bleeding platelet, we accept up to 30,000. If bleeding, we try to maintain platelet more than 75,000. Sedation, if there's asynchronous bleeding, we try to keep the patient awake, especially after the 4 to 5 days of patient on VV ECMO. Okay. And these are our investigation protocols: CBC twice a day, ABG twice a day, SCT 4 hourly, PT, PTT once in a day, okay. Fibrinogen once in 3 days. And whenever there's a bleeding issues, we think of doing take. Okay. Nutrition, I just keep it, general nursing home. Winning from ECMO, once the lung starts recovery, the pump, usually we get the pump flow down, decrease the ECMO flow to moderate flow around 3 to 3.5 liters. And then we start decreasing the FiO2 by 5% every 1 to 2 hourly. Once it comes to effort of 50%, we go for oxygen challenge test. If that is fine, we start decreasing the sweep gas and we stop the ECMO completely. Last 2 slides. Control PCO2 with the help of gas flow, control PO2 with the help of blood flow. Do not exceed the pressure limits, maintain venous pressure to decrease hemolysis. If required, put additional cannula, control cardiac output to take care of recirculation. Cool the patient, because hypothermia, oxygenation is an issue. Try to maintain high hematocrit if the oxygenation is issue. But most important is give rest to the lungs. So what is the important message is you have to keep yourself patience, keep patient alive and do not harm. Thank you.
You're just the best teacher we know for VV ECMO and all kinds of ECMO. Thank you for your active participation. I can see a beautiful chapter on VV ECMO unfolding. After Dr. Pranay's talk on recirculation, on ECMO flows, on cardiac output, and how the two combined tell us about PaCO2 and what to do, we have Dr. Vivek Gupta coming to us. As the chairperson, he is the Chief Director of ECMO and CRRT at the Dayanand Medical College in Ludhiana. With an active interest, he is the chairman of the Simulation and Education Society of SWAC also, and he's been a very, very active member from Northwest India and the whole of India for dealing with CRRT and ECMO, for toxicology, for alum poisoning, and it's wonderful the way he's treated his patients at DMC and in other places. Over to him to introduce our next speaker for the day. Over to Vivek.
Thank you very much, ma'am, for the kind introduction. To proceed further for the academic feast, I invite Dr. Venkat Goyal. Truly speaking, Dr. Venkat Goyal doesn't require any introduction. He is a consultant interventionist and with a special interest in the heart failure at Riddhi Vinayak Institute, Mumbai. But to add in his work towards the contribution towards the ECMO, he is basically a pioneer to start ECMO in the country of ICU ECMO. He has initiated the ECMO Society of India. He has a vast experience of more than 300 of ECMO runs in the intensive care unit. And he has done a fellowship in the MCS at Berlin. And he has been awarded a prestigious fellowship award from Extracurricular Life Support Organization. So I request Dr. Venkat Goyal to speak on all about VA. Over to you, sir.
Thank you, Dr. Vivek. Thank you, Madam Poonam. Please
Welcome,
share
sir.
the screen. My screen is visible?
Yes, it is. Yes, it is.
Okay, thank you. Okay, VA ECMO. The few basic aspects of VA ECMO will be covered and is being covered. So I will only look at the portion which is not being covered. The indications, advantages, disadvantages, monitoring, management, complications, and weaning. There are two types of ECMO, VA and VV ECMO. In VA ECMO, the blood is drained through a vein, oxygenated, and reinfused back into an artery. There has been a tug of war initially from 1975 to 1990, or rather 2000. It was pediatric VA ECMO, then the adult respiratory ECMO became a fashion for VV ECMO. Then after 2010, again the adult cardiac ECMO gained popularity. So it's again now VA ECMO. So the pendulum keeps on shifting. Basically, VA ECMO is a support for a dysfunctional myocardium.
Dr. Venkat, can I disturb you? Can you be on the slideshow mode so that we have the full screen, please?
1 second.
Play.
It's clear? Yeah.
Yes.
So, what does cardiopulmonary bypass causes? It causes myocardial dysfunction by inflammatory response, myocardial ischemia, and hypothermia, reperfusion injuries, inadequate myocardial perfusion, and direct ventriculotomy. The causes of myocardial unepinesis is surgery and medical conditions. In medical conditions, myocarditis, cardiomyopathy, dysarrhythmias, drug effect, transplant rejection, sepsis, and metabolic diseases. We apply a mechanical circulatory support for short term and long term. If it is around 30 days, ECMO is a good alternative, and long term support by mechanical circulatory support.
Sorry, Dr. Venkat. Sorry, your slides are not moving.
Not moving. It's moving in front of me.
And also not in the slide mode.
Not in the slide mode.
Yeah.
Sir, you stop sharing and share it again. It will work.
Okay, okay. Is moving now?
Yes, sir.
Okay. Sorry, so much sorry. So among the support, short term and long term, then indications of mechanical support are bridge to recovery, bridge to transplant, and pre-operative stabilization. Bridge to recovery is for short conditions like myocarditis and post-operative cardiotomy. Irreversible dysfunction requires a bridge to transplant, and for pre-operative stabilization for congenital heart disease, for pulmonary hypertensive crisis, and other operations. The important thing is the entire application is for a potentially reversible situation, and there are no absolute contraindications. So, emergency mechanical support is for cardiopulmonary resuscitation, severe pulmonary hypertension, and malignant dysarrhythmias. And other conditions can be emergency situations, low cardiac output, and high category demand. Miscellaneous indications for VA ECMO, tracheal reconstruction, poisoning, myocardial trauma, hypothermia, sepsis, and non-heart beating organ donation. Recent addition are applications of ECMO for supportive purpose, like in cath lab, in acute MI, and cardiogenic shock. In terms of figures, the application of VA ECMO is for a cardiac index less than 2 liters per minute, for metabolic acid with the base deficit more than 5, blood pressure of less than 60 in adults and 40 in children, and after a technically satisfactory repair but failure to wean off. Contraindications are major brain damage, prolonged shock, and after a technically unsatisfactory repair. What is the effect of VA ECMO? It decreases the preload, it increases the afterload, it increases the systemic blood flow, it decreases the pulmonary blood flow, and there's a differential circulation and left heart stasis. Advantages of VA ECMO is that it is easy to cannulate and it gives an instant circulant respiratory support. and instant hemodynamic stability and no recirculation. But the disadvantages are many. The disadvantage of cannulating in major artery and the risk of embolization, the coronary and the cerebral hypoperfusion, non-pulsatile flow, left ventricular distension, cardiac stunning, and neurological events. So if we are trying to use the VA ECMO with this inotrope score at a point more than 20 points of inotrope, we should be considering a VA ECMO, but I find we keep on delaying it for more than 60, 80, or even 100 points, and that is the main reason for poor outcome. This is the circuit for VA ECMO. Everybody knows it. Physiology, Dr. Muralidhar has already explained, but I just want to highlight a very important point. In VA ECMO, the entire right ventricle, lungs, and the left heart is parsed out, and there's an abnormal physiological circuit, which is the ECMO circuit outside the body. And this parsed out right ventricle to left ventricle is the main cause of all the complications related to VA ECMO. As we all know, the VA circuit is something like we drain the blood from the femoral vein and return it back to the femoral artery. And if required, if we need to do modification, we can do a VAV and VAA modification depending upon the situations arising as a result of VA ECMO. The cannulations are standard, but the important aspect of cannulation is an antegrade cannula, which has to be put to the returning cannula because of the spasm around the returning cannula. So there has to be a distal limb perfusion by an antegrade small cannula in the same vessel, causing to prevent a distal limb ischemia. These are the basic cannulas: 70 to 24 French in the arterial side, 23 to 25, or if it's a large patient, are up to 31 French in the venous cannula. We have to maintain the venous pressure less than 60 and arterial cannula less than 300. Sometimes central cannulations may be required, whereby we are draining the blood from the atrium and returning back to the aorta. And this is a side. So once we have selected all the components, we get started. We have a circuit, we have done the cannulation, we set up the heparinization, and the initiation of therapy is being started with lung management. ICC management of ECMO, the point is between ECMO and the patient hemodynamics, the ECMO and the patient gas exchange. The investigative tools, radiology and the echocardiography are very important to judge the progress and the outcome of the VA ECMO. Others are ventilation, inotrope, sedation, nutrition, infection, bleeding, thrombosis, etc. So all this focus of ICU management will not be possible in this 20 minutes, but these are standard for any ECMO procedure. But what are we looking at? Three things for the circuit, that is accuracy, efficacy, and safety. The hardware has to be accurate. You have to check for the circuit every hour. You have to check the machine for blood flow rate, gas flow rate, revolutions per minute, ECMO FiO2, and the oxygenator for delta pressure and post-membrane of gradients. Then the efficacy of the circuit by clinical and the biochemical parameters. And goal is to maintain the adequate tissue perfusion with minimum complications. And VA ECMO efficacy assessed by mean arterial pressure of 60, mean venous oxygen saturation of 70, lactate less than 4, and a cardiac output of more than 2.5. Then the safety of ECMO parameters, the coagulation profile, the hematological profile, biochemical profile, and the clinical, radiological, echo, and the carbon dioxide cardiac output profile. They will determine the safety of the circuit on the patient. Thus, these are a few of the pictures to show you that on the machine component, these parameters are already reflected in machine. Each machine has a different console. We are necessarily requiring a carbon dioxide and SpO2 monitoring. Then online monitoring devices are also there. Then you find sudden ECMO flows and ECMO speed this mismatch, which is because of either chattering or because of spasm or because of hypovolemia. Then instant variations has to be very carefully monitored. And if you find conditions whereby the ECMO flow increases, then what happens to preload, afterload, and contractility, and vice versa. So these things are part and parcel of your understanding about VA ECMO, and they have to be carefully worked out to prevent the complications as a result of excess flows. The P1, P2, and P3 pressures in the ECMO circuit, pre-pump, pre-oxygenator, and post-oxygenator pressures are Very important, they give you the status of the integrity of the ECMO circuit outside the patient. And if the P1, P2, P3 are increased or decreased, then they will help you in the diagnosis to find out what is happening on the patient. So these charts should always be on the wall of near the ECMO patient to keep on giving you an idea if the things are changing shape. Then the gas flows, the oxygen and the air, the sweep gas and the FiO2, the oxygenator for venous side and the arterial side for clots and fibrin, and maintaining the carbon dioxide concentration and to assess the time for weaning off. So these are important from the point of the circuit. Now the patient parameters, you have to look for the vitals, the ECG rhythm, pulse, invasive arterial BP pressure of 70 to 90, filling pressure of CVP, pulmonary capillary wedge pressure, left ventricular end diastolic pressure, temperature, respiratory rate, urine output. Then the patient parameters, gas exchange and tissue perfusion, SpO2, SCVO2, lactate level, cerebral saturation, and capnography. The goal is the ventilator strategies. The goal is to have a rest lung settings, to have a low rate, low inspiratory time, low tidal volume, low plateau inspiratory pressures, low FiO2, low PEEP, and to have an ultimate goal is to extubate and keep the patient awake with spontaneous breathing if the lung functioning is okay, and to also monitor the pulmonary perfusion, the lung status, the helping the lung status by HFFV and nitric oxide. Fluid and electrolyte management, they are same as in any other ICU. The management is to keep the patient as dry as possible with aggressive diuretic therapy and early CVH if you find renal dysfunction. And if you find a chatter, look for the volume status of the patient. If there's a renal failure, you have to look for urine output and to control the edema by diuretics and hemofiltration, early CVH, and maintain euvolemia. Sedation, nutrition, hemodynamic management of hypotension during VA. That is important. You have to correct the hemoglobin, correct the vasodilatory shock, use inotropics required, and IBP may benefit. Then ECMO and infection, ECMO and hemolysis, ECMO and biological monitoring of arterial and venous blood gases, lactates, hemoglobin, hemoglobin levels, renal and liver dysfunctions, and renal and liver functions and coagulation profile. They comes into the aspects of biological monitoring during ECMO. Look for the complication like arrhythmia, hypotension, pulmonary edema, then internal bleeding, thrombosis, and then mechanical like vascular injury due to cannulation, hematoma, hemolysis, gas embolism, and limb ischemia. Then the special problems related to VECMO, they are differential circulation, myocardial stunning, then left heart stasis and limb ischemia. In limb ischemia, the causes is arterial embolism, hematoma compression, femoral artery cannulation is too large to allow retrograde perfusion. You have to monitor clinically by feeling the pulse and the vascular Doppler, and management is by a distal perfusion catheter and surgical intervention. This is just to show the setting in of cyanosis, then causing blisters and compartment syndrome, limb edema, and the solution is to give an antegrade distal limb perfusion. This is just a diagram to show the same thing. This is the antegrade, this is a retrograde catheter, and this is an antegrade catheter, which is shown here, which will help to prevent the distal limb ischemia. Same thing here. So you have to have an antegrade line, and you have to look for, if that is not possible, you have to go for a posterior tibial cut down. Then the second thing is differential circulation, the north-south syndrome in VA ECMO. When the cardiac contractility improves, then the antegrade flow, which is deoxygenated from the left ventricle, tries to cross the arch of aorta. Thereby, there is a decreased oxygenation into the carotids and the cerebral, and therefore the upper limbs are blue and the lower limbs are red, and this causes a cerebral hypoxia. So this is what we call as the Harlequin syndrome, and for this you have to make some settings by either increasing the venous flow or the oxygenated blood flow across the right atrium, or by adding an additional cannula into the axillary artery into the ascending aorta, which contains oxygenated blood. So therefore that would help to decrease the deoxygenated part in the arch of aorta, particularly the ascending aorta. So that is the blue, red. Okay. Then the patient of the other management is ventilator settings. treatment of the etiology, axillary artery cannulation, VAV cannulation, and converting VA ECMO to VV ECMO. So this is just to show you to convert into a VAV cannula, which was increasing the blood flow, oxygenated blood by the right atrium, right ventricle to the left ventricle. Then comes the next stage is cardiac stun. The cardiac stun will lead rise to left heart stasis. The left heart stasis will cause raised LVTP. The raised LVTP will cause increase in left atrial pressure. Left atrial pressure will cause pulmonary edema and will cause pulmonary arterial hypertension. And the stasis will lead to formation of clots, and therefore you require a LV venting. Now, between cardiac stun and left heart stasis or left ventricular distension, there is a hairline difference. If it is a transient thing as a result of severe myocardial insult, it may be a cardiac stun without a raised LVDP or without a cardiac standstill. Otherwise, cardiac stun may progress to left heart stasis if the heart is not contracting. But treatment by and large remains the same both for cardiac stun and left ventricular distension, left atrial hypertrophy, etc., etc. So the effect of myocardial stun would be decreased left ventricular ejection, over distension and dilatation of LV, mitral valve regurgitation, pulmonary edema, pulmonary hemorrhages, thrombus formation. And non-surgical interventions are increase the preload or add inotropes or decrease the ECMO flow or correct the electrolyte imbalance. And mechanical support would be an IVP and left ventricular venting. So if this would work, this is to show you, this is the myocardial stunning. See the poor contractility of the LV with mitral regurgitation, ejection fraction around 20-25%. Now, after the heart improves, you can see the increased contractility. The ejection fraction is above 40%, and the blood flows are better. The rate of contraction is more. LV is still distended, but the contractility is improved. The method of LV decompression: percutaneous IVP, impella, transseptal LV cannulation, atrial septostomy. Surgical is by direct left ventriculotomy or by left atrial cannulation. Non-invasive is by reducing the inotrope support and reducing the ECMO flow. So the consequences of left heart stasis are left heart thrombosis, pulmonary edema, increased left ventricular tension, decreased coronary blood flow, thereby resulting into the radiological changes and decreased cardiac output and hemodynamic instability. So, one second. This is the radiological picture where you find increasing pulmonary congestion, then pulmonary fluid all around. Then as progressive, the heart enlarges, the pulmonary edema increases, and almost this is a white lung. As the congestion improves, the causes of left atrial hypertension during VA ECMO is severe left ventricular dysfunction, high bronchial air return to left atrium, incomplete capture of venous return, aortic valve insufficiency. What is the treatment? Cause left atrial septostomy, create pulmonary to tricuspid valve insufficiency, use the impella pump, cannulate the left atrium and cannulate the pulmonary artery. This is a method to cause a balloon atrial septostomy and decreasing the left atrial hypertension. This is just to show you by putting two catheters into the venous side to decrease the blood return to the left atrium, thereby decreasing the left heart stasis. This is a method of left ventriculotomy by causing a LV venting. Then the other complications are left ventricular thrombus. In left ventricular thrombus, there is requirement of frequent transthoracic and transesophageal echocardiography, and it may be difficult because of weaning and ventriculotomy required to remove the clots. This is a LA clot, this is a LV clot, this is an aortic clot, and management is add dobutamine, add intra-aortic balloon pump, do balloon atrial septostomy, and a pulmonary artery drainage catheter impella, and so switch over to a central ECMO. Venting option is through a blade, balloon, or radiofrequency, and a right superior pulmonary venous vein venting, or a direct LV venting. These are few of the obsolete cannulas. A smart cannula was there previously, which used to fit into the size of the pulmonary artery. The passage was via the tricuspid valve to the pulmonary valve into the pulmonary artery, and therefore the blood was returning freely by causing a complete obliteration or complete non-functioning pulmonary valve in the tricuspid valve, thereby decreasing the LA pressure. Other temporary mechanical circulatory devices for left ventricular stenosis are tandem heart and impella, and IVP, of course. These are few of the pictures. Impella goes directly from the aorta to the LV. Tandem heart goes by the IVC to the right atrium across the IAS into the left atrium. Then cerebral hypoxia is a very important point because of, again, north-south syndrome. And you have to look for the other components of hypoxia. And you may monitor cerebral hypoxia with the cerebral oxygenators, which involves cerebral oxygenators to see the oxygen saturation levels. And they might help you to diagnose cerebral hypoxia and even intracerebral bleed, etc. The method of treatment is VVA or VAV modification of the circuit. Then cardiac ECMO in children, it basically depends upon the experience of the center for congenital heart disease surgeries. Isolated left ventricular failure is rare. It is a combination of right ventricular failure, pulmonary hypertension, and hypoxia. And ECMO treat all of these conditions. Management, just few pictures of the X-rays to show you, help to tell the position of the lungs, the cannulae, and the heart. The echocardiography, the peristernal short axis view, the left ventricular ejection fraction, the aortic VTI, and the tissue Doppler of EA by assay. Echo is fundamental at the time of cannulation for daily surveillance and for managing the complications. Echo also important for predicting the successful outcome of weaning. Then otherwise, a daily surveillance or weekly surveillance for the lines, for the patient, for the reperfusion lines, for the pump, for the central units, for the membrane, biological surveillance of the bleeding and clotting, which has already been covered by Muralidhar. So I had less time to go through these topics. So bleeding and these are a very important part of managing the ECMO, but we maintain the INR around 160 to 180. Then assess for other complications of hemolysis. And hemolysis, the causes, the monitoring, and the management. So look for red or brown color urine, the elevated potassium levels, onset of renal failure, icterus, etc. Or a plasma hemoglobin levels over 50 mg/% to look for hemolysis. Look for clots in the oxygenator, look for fibrils in the oxygenator. As the number of days of ECMO goes on increasing, the thromboembolic phenomena keeps on increasing. So when do you need to change the entire extracorporeal circulation? When there are massive deposits of fibrin, when there is severe hypoxia, when there's severe thrombocytopenia, the massive hemolysis, membrane rupture, or there is a pump or controller dysfunction, and systemic change every 10 to 15 days if you find the patient is not is in a serious note. Then weaning of ECMO, assess for readiness, reduce the flow, trial of and decannulation. Then for weaning criteria, daily transthoracic echo, weaning attempt of the ECMO if there are no or low catecholamine requirement and there is no right ventricular dilatation and there is progressive reduction of the ECMO from 6633 to less than 10%, and the mean artery pressure does not drop below 60. And then when everything is okay, then you have to clamp the line for 1 to 2 minutes and remove the catheter in the OR. Trial of, there's a sequence of events to do it, and that graph is given here. There are prerequisites and there are stopping criteria. If all the prerequisites are maintained, the predictor of successful decannulations are being followed. You go on step by step in a stage 1, 2, 3 mechanism and keep on reducing flow to less than 1 liter. And finally, you take the patient for decannulation in OR. Conclusion, the time limitations for ECMO are around 15 to 20 days or maybe 30 days for a VA ECMO. Patient has to be kept on supine. The local complications are always there. Stroke, ischemia, hemorrhage are more common than VV ECMO. And it is a highly preload and afterload dependent circuit and a non-pulsatile circuit. To maximize the VA ECMO survival by patient selection, early implementation, high flows, high BP, avoid peripheral complications. VV ECMO might be better than VA ECMO because the cannulation is easy and the complications are less. So we try to start every patient with VV ECMO because the VA ECMO has few complications. As you have always seen in the statistics, the adult cardiac and the adult respiratory ECMOs have taken an upper hand after 2010 onwards, and therefore more and more VA ECMO and more challenges are coming forward. So take home messages are VA ECMO is the keystone of adult and pediatric cardiac ECMO. Adult cardiac ECMO is getting more and more applications. Newer applications in future of VA ECMO is phenomenal. It is a gradually competing with mechanical circuit to support a short-term VAD, and early applications are key of success. And VA ECMO is the most economical. Thank you very much.
Thank you very much, sir, for comprehensively covering every aspect of the VA ECMO in such a short time. So house is open for questions. If anybody has a question, please unmute yourself and you can ask question.
One question only for paucity of time.
Right.
One question. Dr. Venkat, can I ask you a small question? How do you
Yes,
say
madam.
that VA ECMO is the most economical ECMO? You can't
Because,
predict
madam,
the number of days, right?
because the heart either improves or does not improve. You have the answer in 1 week. Either
Okay.
you are looking for VAD or you have to give up the ECMO. In respiratory cases, after 2 months, there's a hope that the lung might recover. So you get an answer in VA ECMO in 1 week that we have to go forward or you have to stop ECMO.
So that means
So I call it.
when we start an ECMO, we come to know where we stand in a
Yes.
VA ECMO.
Sir, there is a question, cannulation strategy in VA ECMO in case of AR.
Yes, that's a good question. In AR, usually it is contraindicated, but if you find that way, from the axillary artery, you can take the cannula downward across the arch of aorta and place the cannula in the descending aorta. So thereby, you will not be directly facing the aortic valve.
At all
Right.
times.
Thank you, sir.
So thank you both, Dr. Vivek as well as Dr. Venkat, for a very lucid presentation and a good peep into both VV by Dr. Pranay and VA. I thank ECMO Society of India and the way I have learned ECMO from all of them. Thank you so much. Thank you. Please be with us again. I invite now our next chairperson, which is Dr. Minati Chaudhary. Dr. Minati is a professor of cardiac anesthesia and critical care at AIIMS. She, with her 25 years of experience in cardiac critical care, is a very tall figure in her academics, in the way she presents, and the way she has fought to be the winner that she is. Minati, please introduce our next speaker and welcome to this program.
Thank you, ma'am. And I'm sincerely honored to introduce our next speaker, Dr. Yatin Mehta, who is a real stalwart in the field of cardiac anesthesia and critical care. He is an enormous degree holder and tremendous contribution to the field of cardiac anesthesia and critical care. He is the past chairperson, SWACELSO, and president of the Simulation Society. He is the president in the Sepsis Forum of India, past president in several societies like IJCCM, Research Society of Anesthesiology and Pharmacology, as well as IAPTA. He has special interest in critical care, and he formulated the practice guideline for nutrition in critically ill patient and for enteral nutrition management in dysglycemic critically ill children. So he is going to tell us about the use of cytosub in ECMO. Yatin Mehta, sir, please, the mic is now yours.
Good evening, everybody. Welcome you to this TSS conference on simulation in ECMO. It's a very important subject. So I'm going to talk today about use of ECMO in cytosol. So this was the SWACELSO annual conference in Riyadh, and the organizer of your meeting, Professor Poonam Malhotra, took over as the president of SWACELSO. So
Sir, you are not audible, sir.
These are all the leaders of ECMO in Asia and Africa. So what is cytosol adsorber? Well, basically, it's an adsorber. It's a highly composed of highly biocompatible porous polymer beads with numerous pores. The surface area is humongous. It's about 45,000 square meter, and each bead is of the size of a grain of salt. And it absorbs it's a concentration dependent absorption. That means the higher the concentration of any agent within that molecular weight range, more the absorption. And as the concentration falls, the gradient falls and the absorption is reduced. So it does not completely remove all the cytokines and other molecules, but it restores the normal physiology and restores the balance of the immune response. So it absorbs all the molecules between 5 to 65 kilodaltons. So it does not absorb albumin, does not absorb immunoglobulins. So patient's own immunity is not really affected. What are the molecules which it absorbs? When it removes the inflammatory mediators, pro as well as anti-inflammatory mediators, cytokines primarily. Also, it absorbs certain newer NOACs like rivaroxaban and ticagrelor. We are seeing more often in the cardiology patients. Also, in liver failure, it has been used extensively because it absorbs bilirubin and absorbs myoglobin. So it's been used for rhabdomyolysis. The primary indication remains sepsis and septic vasoparetic shock. So all the inflammatory markers are absorbed. It's been used in COVID-19 extensively. It's used extensively in cardiac surgery, emergency as well as elective surgery, also for liver failure and rhabdomyolysis, as I said. Remember, it's basically an adjunctive therapy. So all the basic measures of surviving sepsis should be implemented before you use this device. That means initial resuscitation with fluid and vasopressors, source control, and organ support. And only then the role of cytosorb comes into play. So initially, any serious infection or inflammation, there is SIRS-like syndrome. You initially resuscitate the patient, organ support and so on. Still remains patient on high vasopressors, then that's the time to think about cytosorb. This was a case series, large case series, which we'd had about 100 patients in patients with septic shock at Medanta. And we found a significant reduction in vasopressor requirement, significant reduction in inflammatory markers, including PCT and IL-6 and TNF-alpha, and also significantly reduction in mortality compared to the historical controls. So it is primarily used in vasoplegic and septic shock. When there is a vasoplegia, patient has a cytokine storm, refractory hypotension, microcirculatory disorder, so perfusion of the tissue suffers, lactate is increasing, and ultimately septic cardiomyopathy may happen. So it restores the capillary integrity, it reduces the vasopressor requirement, improves the microcirculation, and may improve cardiac function. This was a series we published in patients undergoing major aortic surgery. Since many of you are involved in cardiac surgery and cardiology care. So this is a series we did in big aortic surgery, major aortic surgery at our center. We found a significant less mobility, reduced ICU and hospital length of stay, improved PF ratios, a reduction in cytokine and vasopressor requirement in patients in whom we used the device compared to the control. So what is the rationale of using this on patients on ECMO? Well, obviously, ECMO patients are sicker patients. They already have multi-organ failure. Their cellular function is deteriorating. Their fibrinolysis is there. Complement activation has happened. Increased inflammatory markers are there. There's hemolysis. Increased maybe bilirubin and organ hypoperfusion. Non-pulsatile flow does not help this. And obviously, the foreign surfaces also do not help if they activate the cytokines and coagulation cascade. So they already have a SIRS-like syndrome. They may be on VA or VV ECMO, and there is no real one effective strategy to reduce the inflammation and organ perfusion in these patients. So cytosorb absorption may be an adjunctive therapy in this group of patients. So when should you think about using cytosorb in ECMO patients? Well, primary indication does remain septic shock, cardiogenic shock, ECPR, while you're waiting for transplant or LVAD support. So bridge to ventricular assist devices, post-cardiotomy, heart failure, liver failure, septic shock, rhabdomyolysis, and infective endocarditis remains an important indication in these patients. And how it is very, very simple to integrate. We will be shown this in hands-on workshop tomorrow. And here you can see this is the venous return coming from the patient. This is the pump, centrifugal pump, and this is being pumped through the oxygenator back to the patient. So you take a line from here just before the just before the oxygenator. So blood goes from here into the cytosol. The flow rate is about 350 to maximum 500 mils per minute, and this goes through here and goes back to the before the pump. So it recirculates. So this is very easy to integrate. And diagrammatically, this is what it looks like. The venous return is coming to the rotor pump. So you take a line after the rotor pump because it requires a pressure head before the oxygenator. This blood is going to the oxygenator and back to the patient. So you take a line from here, which goes to the cytosol and again goes back. So it runs in parallel to the circuit. And here it demonstrates the different connections in these patients. So from a high pressure circuit after the pump, you take a line and which goes to the low pressure circuit because you require a pump head, pressure head. So this is a low pressure, this is a high pressure after the pump. Similarly, here it shows from the high pressure to the low pressure. This is the cytosol absorber, and this is your oxygenator. And here you can see that when it is connected and cytosol is turned off, also there is no real change in the flow and in the output. So there is no significant change in the flow. So really, this much of flow does not affect the performance of the ECMO. So what is the evidence so far of its use in ECMO support? Well, it does improve hemodynamics, decrease experimentally. It has been shown to reduces capillary leakage and it shows integrity. It invariably reduces the catecholamines and metabolic parameters do get stabilized. So this was a series from Chicago in ECMO. So no talk in present times can be finished without we talk about ECMO. So these were COVID-19 patients and 52 ICU patients in 5 American ICUs, and they found an ICU mortality of 30 days of 17% and 26% in 90 days. So this is significantly reduced mortality compared to the historical control in patients with COVID-19. Here you can see cytosol, when it was used along with ECMO, survival at 90 days was 73% compared to 50% with only ECMO. So significant improvement in survival, and it has been found to be effective in COVID-19. And here you can see combined ECMO in patients with the pneumonia, severe pneumonia. There's a series of patients. There was significant reduction in norepinephrine level requirement. As you can see, significant reduction in CRP and PCT, and 30-day survival in the cytosol group was 100% compared to 43% in the control group. So pretty convincing evidence. And this was another 7 patients case series and patients with ARDS. There was a significant improvement in respiratory parameters as evidenced by reduction in PEEP requirement, reduction in Pmax, reduction in lactate levels, and vasopressor requirement was down by 81%. So there was hemodynamic stabilization, respiratory stabilization, reduction in lactate levels, and predicted mortality was in this group of patients significantly reduced. ECS, there is another case series. This was a retrospective series of 23 patients, CRRT along with ECLS and cytosol. There was a reduction in cytokine levels, reduction in vasopressor requirement, and potential improvement in organ failure. So this was a series of cases of ECMO with cytosol. This was a negative study. In this series, 4 patients with drug overdose, VA ECMO was used with cytosol, and significant reduction with the toxic levels of the drug. In this 14-patient series, VA ECMO, and 29 without ECMO, cytosol with RRT and rhabdomyolysis, there was a significant reduction in myoglobin. We have also shown this in another publication. Akil et al., as I showed and already discussed these slides earlier, significant improvement in survival. 8 patients, Reader et al., COVID-19, VV ECMO, and 4 received cytosol. Significant decline in IL-6 levels with CytoSorb level. Kugelman has done a lot of work on CytoSorb device, and in this series of 7 ARDS patients, VV ECMO, significant reduction in lactate and decline in vasopressor requirement. Trigger in 2020, 23 patients, VA ECMO, RRT and CytoSorb, reduction in inflammatory mediators, usages, and lactate levels. And this is a large series, last by Calabaro et al. In 2019, 40 patients with cardiogenic or septic shock, ARDS or liver failure, that is multi-organ failure, 19 patients with ECMO, bilirubin, lactate, CK, and LDH levels significantly reduced, and survival significantly better compared to the expected survival. And these were some cases where the patient with cardiogenic septic shock, heart failure, and this was H1N1 pneumonia with staph pneumonia, ARDS. There was a significant improvement in these patients. So CytoSorb with ECMO is a safe device to use. There's no significant removal of albumin, immunoglobulins, coagulation factors. There's no complete removal of physiological mediators. It only restores the balance. It does not bring them down to zero. They're highly biocompatible, so there is no hemolysis issue. There's no activation of coagulation and complement systems, and very, very less use of platelet. I've never really had to administer platelet transfusions in patients of CytoSorb. So CytoSorb therapy is safe, easy to use, extremely versatile in application, and well tolerated with no evidence of device-related adverse events. Now, when should we use this? Well, when vasopressor dose is low and IL-6 levels are low, don't think about it. Only IL-6 levels are high, but vasopressor is not there, then re-evaluate it 2 to 4 hours. If both are low, do not consider it. If vasopressor dose is low, IL-6 levels are high, again re-evaluate. If vasopressor dose is increasing, but IL-6 levels is low, re-evaluate, but IL-6 levels is high, you consider CytoSorb. They're moderate to high, then consider CytoSorb. Do not delay it too much. Earlier you use it, the better the results. So early initiation, start of our ECMO therapy. You already started ECMO therapy. Consider early use of CytoSorb in anticipation if the patient is deteriorating or if lactate is increasing. Patient is stabilizing. In hemodynamics, much better, 80% reduction in vasopressor requirement. Patient is recovering. Do not use the second device. There is no control of shock parameters. You can start CytoSorb and use a second device. There is sufficient stabilization. You may stop use. There is insufficient stabilization or stabilization, which after stopping the device use regresses. You can re-evaluate and use the second device or third device, and so on. If it doesn't help after 2 or 3 adsorbers, then just it's not going to work. It's too late to work. So, concluding, CytoSorb represents a potentially useful therapeutic tool in patients with ECMO. Currently, parameters for decision-making should include but shall not be restricted to signs of shock, vasopressor dosage, IL-6, lactate clearance, bilirubin and myoglobin plasma levels. Based on clinical experience, profound shock on ECMO, ECPR, post-cardiotomy ECMO in patients with infection and ECMO in the context of organ donation represent potential indications to date of CytoSorb use on ECMO. So I thank you very much for your attention and wish you all the best for the rest of the meeting.
Thank you, sir. So many people have said that it is not audible. Actually, this is a recorded version. Probably there are some technical issues, so many part of the things were not audible. But CytoSorb in general is exactly not a recent concept. This started, the first animal experiment started long back in 2005 on the rats, just to see how much it can reduce the inflammation. Then there are lot many things has come up like polymyxin B and so many other things, whether they can reduce the inflammation in the blood system. But however, everything has its own advantage or disadvantage. Then several filters have come, and many people have seen that it is the lipopolysaccharide which is responsible for the many patients who are suffering from inflammation and infection while on the ECMO. It is not exactly the endotoxin always. So that's how the cytosurf has started. And till date, there are more than 70,000 people across the world, 70,000 patients. They got benefited with the cytosurf use across the globe. This basically reduces not only the inflammatory mediator like the IL-6, that is a pro-inflammatory mediator, and the improve the hemodynamic instability also in many of the patients who are receiving it. In the initial studies, they used to put it as the either pre and post hemofilter circuit, but now they are attaching with it the main ECMO circuit. We are also using in many of our patients in our ICU, and it is really a lot of benefit by improving the lactate level, improving the hemodynamic, improving the oxygenation. And but however, we need
Especially
a
in
different
sepsis.
setup of the patient and large number of patients to conclude its real efficacy.
Thank you, Dr. Minati. I think there is now a lot of competition on different heme adsorption devices, as you rightly said, and integrating these devices into ECMO to remove the systemic inflammatory response is what is the need of the hour. For all of those who have missed out on this or any other talk so far or want to hear to the link, you can go on to the YouTube link, whose link we will be sharing at the end of this session today. So, thank you Minati again, and thank you to Dr. Yatin Mehta, our TSS National President. I thank all of you and would like to go ahead and bring about a small notification that Dr. Naman Shastri's talk will be in paucity of time for travel after the complication of ECMO panel discussion. We have now Dr. Parag Garde for chairing the next session by Dr. Vivek Gupta. Is Parag there? Has he joined? If he hasn't joined, then it is my proud privilege to introduce Vivek again. Vivek is one of the most dynamic ECMO intensivists in the country. Not only does he do ECMO, he is a director of ECMO and CRRT and a critical care intensivist at the Anand Medical College, Ludhiana. As the person whose brain behind ECMO Society of India's fight in toxicology and ECMO with CRRT, I know that not only is he a good coordinator, but also the organizing secretary for the next SWAC also 2023 at Ludhiana. And I would be very interested in learning from him what more does he have to say in ECMO and toxicology. So over to Dr. Vivek Gupta on a very unique topic on how he uses ECMO for toxins like alum poisoning. Over to you.
Thank you, ma'am. Thanks for the kind introduction. Is my screen visible?
Yes, it is. Yes, it is.
Okay. First of all, thank you, ma'am, for giving me this opportunity to talk on such an important topic related with the ECMO. So I have nothing to disclose. I will start my discussion with a case which we have done just 3 days back. So it's an actual real scenario. A 44-year-old male patient who was admitted in the morning around 10:30 in the main hospital emergency department with a history of taking sulfas, 2 tablets at 5 a.m. on the same day. He was initially followed all protocols, administering fluid, vasopressors to stabilize him, along with the other magnesium and steroid, etc., for medical management. But he remained hemodynamically unstable, and they stepped up the vasopressors, and ultimately they landed up with adding 3 vasopressors, dopamine, norepinephrine, and vasopressin at a pretty high dose. Still, his heart rate was 90 and blood pressure was 84. His ABG was severely acidotic and lactates were more than 50. Bicarb was just 4. So an echo was done, which showed a severe LV and RV dysfunction. He did not have any past history of the cardiac issues, with a global hypokinesia with an ejection fraction of just 15 to 18%. And repeat ABG showed further worsening with a pH of 6.92 and still lactates were more than 15 on ABG. So it was not counting actually, it was much higher. So we started discussing with the relative for supporting with the ECMO and financial and complications and outcome-wise all issues. So this was CG prior to he was shifted to our unit for ECMO support. So while shifting this patient, he has sudden ventricular fibrillation. We immediately started with the CPR. We were fortunate that everything was ready. He was given a shock. CPR was continued. He required multiple shocks and intubated and mechanically ventilated, while an emergent VA ECMO was initiated. You can see this just prior to the VF, we have this kind of ECG, white complexes you can see with a just blood pressure of 78 or 80 in the range with a very, very high inotropic support. So we initiated a VA ECMO with a 17 French arterial, 25 French venous cannula with a distal perfusion was maintained with a 7 French sheath, and this was right femorofemoral access. We initiated and gradually went up to the 3.2 liter of flow with the roughly around 3000 RPM. CPR is stopped as soon as we initiated the ECMO, and vasopressors were gradually reduced, targeting a mean arterial pressure of around 70. For next 12 hours, he required multiple shocks every 10-15 minutes. Almost we gave around 50 to 60 shock over that period, and we sent a separate sample for lactate tissues, 23.4 millimole. He had several episodes of hypoglycemia, and his first creatinine noted was 1.79. So it was an AKI, though he was passing a good amount of urine with the adequate fluid resuscitation. There was a mild hepatic dysfunction with a deranged almost 300 to 400 range of SGOT and SGPT. His serial echo started showing after 12 hours some gradual improvement of the LV function. And we were fortunate just in 2 days, we were able to wean and trial off and wean the ECMO. And he was extubated today, this morning only. At present, he is not on any vasopressors. His cardiac functions have improved, and his ABG is now normal, and his lactate at just 1.2. So basically, in last 10 years, since the H1N1 pandemic, there is a lot of interest in the ECMO, and as an intensivist or emergency physicians, we are looking for the various other indications, newer indications for ECMO. So ECMO is not restricted only to operation theater. Our post-cardiac surgical unit are only the few units for some particular indication. And especially from last pandemic of COVID, now the ECMO is considered as a standard of care. Actually, the moment you talk about the ventilatory, we have all seen that when we talk about the ECMO for ventilation for the COVID patients, relative always used to ask what next if it is not maintaining, because everybody was so much aware about the ECMO. So if you look at the poisoning cases, this is a huge burden of poisoning across the world. Almost 2 million people get acute poisoning, and nearly 1.5 lakh people die unintentionally just by accidental poisoning. And if we include this deliberate ingestion of the pesticide or insecticides, almost 1.5 lakh people further die every year. And we can understand very well that poisoning is always underreported, because any patient who is taking it for the self-harm or some homicidal purpose, if the poisoning has been used, possibly these patients do not reach to the hospital. If you have an acute severe intoxication, they just collapse. So, and unfortunately, so far, ECMO is pretty underutilized modality across the globe, because if you look at the American Poison Control Center data of the 38th annual report of 2020, only 4% patients who had a cardiac arrest with a very poor outcome were supported with them. So this is something, a unique modality for the patient who are poisoning, because we understand that these patients recover very quickly once the toxin is out of the body. This is a paper which was published, which has shown a retrospective analysis of 2 years. They studied almost 6,000 patients who had a various poisoning, and almost 20% patients required hospitalization, out of which 10% patients, nearly 118 patients, who required an ICU admission. And they found that the case fatality ratio was almost 77% with a mortality of more than 50%. So you can understand, it's almost 100 patients are dying just in a year period, 1 year period time in one hospital. How much it can be to the other hospitals across the world? If possibly these patients would have supported, none of these patients were supported with ECMO, possibly that would have been helpful in that particular situation. So the different toxic substances actually, it can be drugs or healthcare products. These are usually in the Western world, this is very common, like antiarrhythmics, beta blocker, calcium channel blocker, antidepressant, or recreational drug like cocaine. While in Indian or Asian countries, it is usually insecticide, which are chemicals used for agriculture or industry, pesticide, rodenticides, and even the plant and animal toxin can be life-threatening. So in the Western world, it's a medication which is common. And in the medication, especially the cardiovascular drugs, which are associated with a very, very high mortality. In our countries, our Asian countries, it's insecticides and pesticides. And usually what is being seen, irrespective of the part of the world, it is usually a younger population which is a victim. So how patient dies in poison? This is very important. If we understand this concept, probably we can understand the importance of the ECMO in these. Normally what happens, these patients become hemodynamically unstable, or they have the life-threatening arrhythmia and they suddenly collapse. Or with the toxic substance, they possibly have the respiratory arrest or they develop ARDS. Once this insult progresses further, so there will be a metabolic derangement and we will have the metabolic acidosis. We can have the electrolyte imbalances. These patients usually to maintain the hemodynamics require inotropic support, and that is itself is arrhythmogenic. And if we use antiarrhythmic drugs, they are further depress the myocardium, and even some of these drugs are proarrhythmic as well. So finally, what happens? There is a hypoperfusion and there is a damage to the other organ as well. It all depends on how much duration of the toxins, what quantity, and how severe the toxin was, along with the comorbid condition of the patient itself. So we all know the standard management of the poisoning. We try to stabilize these patients with the fluid and vasopressor resuscitation. We try to remove the toxin from the body if it is removable. We prevent any further absorption. We enhance the poison elimination depending upon what route is possible. If antidote is available, we can administer the antidote. We prevent any re-exposure, and these are all supportive measures. But sometimes the specific antidotes and the conventional therapy actually is not sufficient when there is a life-threatening overdose and patient has collapsed hemodynamics. So any extracorporeal therapy, if we talk, the rationale in the poisoning is it can either remove the toxin or redistribute the toxin. It makes a metabolic correction. It optimizes the hemodynamics by improving the metabolic derangements, and thus it helps in improving the outcome. So we can have a different extracorporeal therapy in the form of renal support therapies like the HDR, SLED, CRRT. We can have a hemoadsorption, hemoperfusion as the advanced therapies. Plasmapheresis and therapeutic plasma exchange is sometimes useful. And ECMO itself has become a very important tool for handling these kinds of a patient who have a life-threatening intoxication in the form of ECMO, and those who are developing the ARDS post-toxin are having a respiratory issues, VVM. So we know that if the dialysable toxin is there, we can always, and patient is allowing, we can always start with the dialysis and we can take out the toxins. But problem occurs because of the non-dialysable toxin, which you cannot dialyze. So all these toxins actually, once there is a myocardial depression, there is a acidosis. So this acidosis further worsens the myocardium by direct and negative inotropic effect, increases the potassium level, and as the acidotic duration increases, this further worsens the metabolic acidosis and lactic acidosis. So this myocardial dysfunction, vicious cycle always goes on. So how the ECMO can be beneficial? Most of the deaths, actually the poisoning occurs because of the cardiovascular collapse. And we know that it is severe, but it is reversible because these patients are usually relatively younger age group and they are usually not with the comorbid condition. So ECMO tries to maintain the tissue perfusion. So all the organ perfusion is maintained, including the kidney and brain. And it supports the failing organ till the toxins either is metabolized or is eliminated from the body. And it helps with the drug distribution from central compartment. So the plasma concentration of drug decreases, toxin decreases, and that helps in the decreasing the severity of the toxin. And if a dialysable toxin is there, so it allows time for using the CRRT or SLED for these patients. So if you look at the indication, ECMO, any patient who is severely poisoned with a life-threatening hemodynamic instability, who is not unresponsive to the conventional inotropic and other management, severe myocardial dysfunction, which is leading to low cardiac output and other organ hypoperfusion, and if the patient is having arrhythmia or cardiac arrest after taking the poison. Our ECMO can be helpful when these drugs have caused the severe ARDS, like inhalational chemicals like paint removers and other chemicals. Our patient has aspirated the organic hydrocarbon, which has led to ARDS. So both VA and ECMO can be helpful as a bridge to recovery. This is the most likely outcome we expect in cases of toxins, because once the toxin is out of the body, we expect that there will be complete recovery. It can be a bridge to antidote sometimes, especially in cases of digitalis toxicity, because digitalis antidote is available, but it's very costly and it has a very small shelf life. So it is not usually available readily. So till the time you are getting an antidote, these FABs for the digitalis, till the time if patient is collapsed, possibly can be kept on ECMO support. Or sometimes it can be used as a bridge to elimination of toxin using the renal replacement therapy. So both these extracorporeal therapy can be combined. And in certain cases, like the paraquat poisoning, when we know that the lungs are not going to recover, these patients can be supported on BP ECMO till the time we get the lung and we can get a lung transplant in these patients. So our experience for both these therapies, we have done so far the 98 patients who really had the severe intoxication, out of which 4 patients had refused, and 94 patients were treated with advanced hemodynamic malnutrition. 8 patients did not require any therapy because we monitored them and we managed them with the medical management only. 19 patients were supported with the CRRT, and out of these, 17 patients actually recovered. Only 1 patient required to switch over to the VECMO, and 1 patient who died refused for VECMO. 70 patients directly supported with the VECMO, and out of which 51 were successfully weaned off, and 48 patients were discharged home. 3 died, 2 because of multi-organ failure after successful removal of VECMO. They developed sepsis and ultimately died, and 1 had the severe ICH, and he was brain dead, and ultimately we had to withdraw the support. So usually when we start with CRRT, these patients, if they have ejection fraction of more than 35%, when we are evaluating these patients, and inotrope supports are not very high, they are moderate support with the borderline hemodynamics, having severe metabolic acidosis and lactic acidosis, and they do not have any life-threatening arrhythmia like runs of VT or ventricular fibrillation. If we talk about VECMO, so far we have done the 72 VECMO for poisoning patients. Successfully weaned off around 69%, and we have discharged home almost 65% patients. All these patients initially were managed medically as per the guideline, and since they were not responding to the conventional management to the hemodynamic instability or cardiovascular collapse, so they were shifted to us for these management. Out of this, 69 aluminum phosphide. 1 recently we have discharged a patient just 1.5 months back of zinc phosphide poisoning after 8 days, 9 days of ECMO support, and 2 patients of amlodipine toxicity we have treated. So I'm restricting myself to the aluminum phosphide poisoning. Total number was 69. Usually younger patient ranging from 17 to 57 of age, 50 male, 19 female, and they had taken ranging from 1 to 5 tablets. And when they reached to us, the time duration was roughly 4 hours to 24 hours. So they, if we look at the mean, it was heart rate was 106. Actually, both extremes were there. Some patients were bradycardic, and some patients were severely tachycardic and even had the atrial fibrillation. Their mean arterial pressure was around 45, and EF was in the range of around 50 to 20%, average of 20. Most of these patients had the tachycardia. Few of them had a bradycardia. 2 patients, 1 had the AV block, and 2 patients required defibrillation because they had the wide complex tachycardia with a severe hypotension, and 4 patients actually required CPR and defibrillation prior to start of VECMO. So all these patients who have the severe LV dysfunction, mean arterial pressure was in the range of 40, and they were tachypneic, hypoxic. Few were intubated and mechanically ventilated. Mostly they were irritable patients. Renal dysfunction, almost half of these patients had the acute kidney injury, and they had the hypernatremia because they were being treated with the soda bicarb very rapidly to correct the acidosis. Almost 1/3 patient had the acute hepatic injury, and they had the frequent episodes of hypoglycemia. The pH was in the range of 7, bicarbonate was in the range of 6, and lactate were in the range of above 20. All these patients. Vasoactive inotropic score was in the range of 88. 30% patients were mechanically ventilated, 4 patients required CPR, and 1 patient was already on CRRT when we switched over to the ECMO. All these patients had a very high CPK-MB, hyperphosphatemia, and multiple patients had the several episodes of hypoglycemia. We all all these patients were supported with VECMO with a duration of 10 to 280 hours. Flow was in the range of 2.8 to 3.6. Mechanical ventilation 10 to 319 hours. Length of ICU stay was 8 to 46. Usual problem initially we had the surgical site bleeding. Gradually we learned and now we know that modified semi-cylindrical technique is a very good to control the bleeding in these patients because we have slugger in place. Two patients require a femoral artery repair and ligation. Two patients, out of which all patients, two patients require amputation in the initial phases. Other non-surgical complications, these patients have the upper GI hemorrhage or hematuria, acute kidney injury, requiring renal replacement therapy, almost 1/3 patients, hepatic dysfunction, sepsis, and one patient had the pump lung and ARDS after successful removal of ECMO, but he was ventilated again and he recovered completely. One patient had a convulsion which was possibly related to the drug itself, and one patient had the ICH and we had to withdraw the support in that patient. So we try to initiate early before the actually a cardiac shock set in. Usually vascular access problem because these patients due to toxin have the severe vasoconstriction. So we prefer a modified surgical technique for surgical cannulation, usually pulsing around the cannula so that if there is a bleeding, once the vasodilatation occurs after ECMO, we can always tighten it. And we always ensure that there is an appropriate distal size of distal perfusion cannula in place to ensure the distal perfusion. Standard monitoring, what we do for VA ECMO, we always prefer to do a right radial artery cannulation and radial right hand saturation to ensure that upper body oxygenation is appropriate. And we reduce gradually the vasoactive substance and we try to achieve a mean artery pressure above 50 to maintain the adequate flow on ECMO. Issues, sometimes there is LV distension and stunning, and which induces the LV thrombus. We always try to ensure that the aortic valve is opening and we are maintaining the LV ejection. Shock if there is arrhythmia, so that we maintain the LV ejection. We avoid antiarrhythmic because if we use it as a myocardial depressant and if we use the xylocard, this can, because this has a membrane stabilizing action, so it interacts with the aluminum phosphide and it can lead to cardiac distal, which can be further a problem. Inotropic support, we always gradually reduce and we are always ready with the IABP, but so far we did not require IABP support for these patients. We avoid to make a too much correction because once the cardiac output improves, then itself metabolic correction starts improving. Because hypernatremia usually is a problem which creates problem afterwards as well. So usually after 4 to 6 hours, if you are maintaining adequate flow, lactic acidosis and metabolic acidosis starts declining. And in next 24 to 48 hours, usually these start settling down, bring down to significantly low level. When we combine the ECMO with the CRRT, when a patient is having acute kidney injury, there is a severe metabolic derangement, not improving in 4 to 6 hours, or fluid resuscitation has been done and patient is in the fluid or low, or there is a severe electrolyte imbalances, or if there is a dialysable toxin, then definitely we can always add this. So usually when we come across with a patient with severe intoxication, how do we choose our therapies for the extracorporeal therapy? Yeah. Sorry, thank you, ma'am. So we do, well, maximum 2 minutes, not more than that. So IV fluid, vasopressors, all supportive therapy. We review the condition, and if it's still LV dysfunction, tissue oxidation is compromised, we do a continuous hemodynamic monitoring. And if there is a persistent signs of shock and it is worsening, then we go for VA. And if it is not, then we try to do with the CRRT. But anytime if there is a cardiovascular collapse, we switch over to the VA. So to conclude, acute severe intoxication with a cardiovascular collapse is associated with a high mortality. The trend of poisoning is different part of the globe. The outcome of ECMO is encouraging as a bridge therapy. However, ECMO is still an underutilized modality in the poisoning cases, even with the severe shock, even after the CPR. We should think about use of ECMO if the hemodynamics of poisoning patient is unresponsive to the conventional therapy. And we need to understand the right time when to start before the end of the damage is setting in. Probably the ECMO should be started prior to this. Thank you very much for your attention. And if you have a question, I'll be happy to.
Presentation for two things. Number one, how to use ECMO and CRRT together, and number two, the kind of toxins that we see at least in the Northwest region. I'm sure when I was doing medicine, we used to see a lot of snake bite venoms, and atropine was the antidote of choice. And from there to ECMO and CRRT, that's how medical science has evolved. Any questions for Dr. Vivek? Any questions? No? Thank you again, Dr.
Thank you, ma'am.
Vivek, and we are looking forward to joining you in Ludhiana soon.
Thank you,
And see you again. Thanks a lot. I have the privilege of introducing Dr. Shambhunath Das, who is a professor with us in AIIMS for the last 21 years. He has been very, very academic and done a lot of research papers, has been speaking at various portfolios, has been the executive member of IACTA, has many publications. And I would just like to ask Dr. Shambhunath Das, what do you think are the complications of ECMO, Shambhu? Where do you envisage our veno-arterial ECMO at AIIMS with its complications that we've seen in the last 20 years? Dr. Shambhu? I think he joined in and he can't listen. He's Dr. Shambhu? Okay, since Dr. Shambhu is not answering, without wasting much time, let's go on and listen to the experts on complications of ECMO. A whole lot of us saw mortality because of sepsis, fungal as well as bacteremia at AIIMS. We see a lot of our protoplasm is very different from the protoplasm of a rich child. Our protoplasm is malnourished. We are protein energy malnourished patients here at our scenario. And the pediatric babies that we were doing were certainly undernourished. But at the same time, besides sepsis, we saw a lot of bleeding, and we did not know how to use our armamentarium well. And we also saw a lot of intracranial hemorrhage in the bleeding in the early days till we moved on to integrated ECMO, and we did see some thrombosis till it was detected and used judiciously with the right anticoagulant. I have the proud privilege of introducing Dr. Rajesh Sharma, who is the president of the Indian Society of Critical Care Medicine, with us today as the chief moderator of our panel discussion on complications of ECMO. Dr. Rajesh Sharma, can I have you? He's been a stalwart in ISCCM in the last 4 years that I've been seeing him actively move from the president-elect to this stage. So many conferences, so many books, he's turned around the very active ISCCM into a super hyperdynamic ISCCM in so many activities, academically and professionally. Over to him to introduce the panel of elite experts with him for this session on complications of ECMO. Dr. Rajesh, it's a privilege to have you here. Please take over.
Thank you, madam. Thanks a lot. Just to correct little bit, I am Mishra. I not so much sorry, but that's okay. That's fine.
Okay.
So
Rajesh Mishra.
This probably one of my favorite discussion we are doing. We have done it many times, and I always feel very honored when I'm asked to do this, because this is one area which really has turned around how we are managing ECMO patient and how outcome in ECMO has changed. So to discuss this panel, we have panelists with us. Dr. Yatin Mehta sir. Sir is there, no? Dr. Mehta sir?
No, sir is not well.
So, Dr. Suresh Rao, sir, I think Dr. Suresh Rao is also replaced by
by Dr. Santosh from the same
Dr.
institution.
Santosh, yeah. And Dr. Santosh. Dr. Santosh, you are there, sir? Dr. Santosh? Dr. Santosh?
Dr. Pranay and Dr. Venkatar, I'll call up Dr. Santosh.
Dr. Sandeep Diwan is not there also, madam?
No.
Dr. Murli Krishna is there?
Yes. Dr. Murli, please join.
Dr. Murli Krishna, yeah. And to Dr. Santosh, and then probably in between I can ask Dr. Poonam also, and sometime needed.
And Dr. Pranay and Dr. Venkat and Dr. Sunil Pubani are there. Dr. Pranay, Dr. Venkat and Dr. Sunil Pubani with Dr. Murli Krishnan will be the panelists for today with you.
Okay. Please thank you, madam. Thanks a lot. I will just ask all panelists, please, can you just unmute yourself as well as Just you can switch on your video also, so we can see. So it will be easy for me to discuss. Dr. Pranay, Dr. Venkat
Yes,
has
sir.
already done. Dr. Venkat has already done it, and Dr. Pomani.
Yes,
Dr.
Dr.
Santosh?
Mishra, I'm here.
Okay. So perfect. So I will just go with I will be quickly covering in next 40 minutes about the possible complication in both VV and VA ECMO. I'm just trying to cover. So I'll just give you a small case scenario, and we go ahead from there. Sorry. Just let me expand it fully. So
Yes, we can see well. We can see well.
Yeah.
Previous one.
Yeah, I'm doing it. I don't know what it is. Why it is hang up? Okay. So we have two case scenario. Like after I'm not reading completely, just after optimizing completely, we have decided a diabetic elderly patient to put for ARDS after optimizing oxygenation to put on VV ECMO, and the second patient for his cardiogenic shock, VSD and MR, and not able to maintain cardiac output and persistent to be in shock. To support his heart, we have decided to put on VA ECMO. So there is a two case scenario which is very classically for which we use VV or VA ECMO. I'll just directly go to the Dr. Venkat. I'll start with Dr. Venkat, sir. Dr. Venkat, very precisely, when we decide to put cannula, particularly VV ECMO and VA ECMO, a quick checklist to prevent the complication, how do you proceed, sir?
First of all, we need to look at the Doppler of the vessels to be very comfortable that there is no kinks or there is no narrowing of the vessel down the line. So if we have a Doppler steady, it is good. Feeling the pulse, of course, is the basic thing. Then having all the accessories of the dilators and the wire and the adequate wire for cannulating. And if we are using an VA ECMO for the arterial side, if we have a possibility of a surgical backup, a cardiac surgeon, in case of bailout situations, then it is a luxury. We can definitely avail it. Of course, a distal limb perfusion for VV ECMO, we don't require distal limb, but otherwise for VV ECMO, the adult VV ECMO, the femoral site and the jugular site, or a double lumen cannula, the ultrasound guidance is required because we need to position the opening of the cannula at the right place. This would help.
Okay, Dr. Pranay, like what are the common problem like when you face when you are doing VV ECMO, and how do you avoid it?
For cannulation or
yeah, for cannulation.
See, the commonest is, first of all, you have to see the size of the vessels and cannulation technique. Usually is a Seldinger method. So bleeding is a risk that remains in case of when we do any cannulation. Other common risks like pneumothorax is going to be a risk. Vessel tearing, vessel dissection. Your cannula size is, if it is bigger than the your vessel size, you may not get adequate flow. Cannula size is small, again you may not get adequate flow. So size of the cannula should match the size of the vessel. For that we have to have Doppler guidings and the position of the cannula. Where is the cannula is? If cannula is moved towards a smaller vessel or something, then again the flow can be an issue. So problem which we can face commonly is the flow issue. That is number one. Number two, in VV ECMO, again, recirculation can be a problem. Both the cannulas are very close to each other. Number two, cannulation related problems like bleeding, hematoma, dissection, pneumothorax. These are the ones which we face commonly.
So how do you avoid? Suppose I want two common problems for recirculation and for bleeding. What do you do to avoid them?
For recirculation, definitely we need to, first of all, the moment we initiate ECMO, we have to see the color difference. If the color difference are good, then there is no recirculation. And then you have to get the position check with the help of Doppler and with the help of X-ray. The minimum distance between the two cannula has to be around 10 centimeters. So in that case, you don't get the recirculation. So usually the drainage cannula, we put it in the femur, hepatic IVC part, and the return cannula we put in the upper RA. That is usually the combination that avoids recirculation or minimizes the recirculation. About bleeding, best is to do a Seldinger technique, and the wire movements should be smooth, the dilator movements should be smooth, and you should not over dilate it. And at the same time, whenever there is a resistance that comes in between, you should stop at that time and try to find out what is the cause for resistance. Otherwise, the wire will get kinked and there is a risk of bleeding will increase.
Okay. Dr. Santosh? Okay. Okay. So Dr. Santosh and Dr. Murli, this question for VA ECMO, you can divide. What is the common problem one can answer about the VA ECMO and how to avoid? So Dr. Murli can talk about the common problem, and Dr. Santosh, how to avoid the common problems.
Common problems while you're planning VA ECMO is, vascular access, if we thoroughly look at it and plan, usually that should go smooth. One of the things which you may face is how to handle the distal perfusion. If the time permits before, you always try to get a femoral access that is in the distal side to put it before, so that you can convert into a distal perfusion cannula once you institute the patient on ECMO. But if the time doesn't permit, the patient doesn't give you time, and then you have to put him on ECMO as soon as possible, then you go ahead, you institute the ECMO. After that, you try to get a distal, which may or may not be feasible, especially if the vessel size is small and you had chosen a little bigger arterial cannula. If you're able to get it ultrasound wise, that's okay. If not, then probably you have to take help of the surgeons there to dissect out and put a distal perfusion cannula under guidance. So that is one of the common problems what you see. Second is if the patient whom we are putting on VA ECMO, if you're having issues there, in the sense that if it is an ECPR, by the time you are instituted the ECMO, a good amount of constrictors in the form of adrenaline and all would have gone in. So then you see that the patient, once you start the ECMO with a centrifugal pump, you won't be able to achieve good flows there. So after checking your cannula position and all, even then you're not having a good flows, probably need a bit of dilator there for the patient to dilate. That is especially after going in a case where you're having an ECPR. Or if you're having, on the contrary, a patient who is in heart failure, whom you are giving dilators, the milrinone for a long time, and then he deteriorates, and then you institute ECMO there. On the contrary, you may see that the perfusion pressures are low and you'll be having a good flows. There you may need to support the perfusion pressures with a dose of constrictors, either NORAD or vaso, till the SVR picks up in those cases.
Okay. So, Dr. Santosh, you have to add anything on this VA ECMO?
So the common problems during cannulation in ECMO mostly related to bleeding, and arterial dissection can happen. So proper ultrasound guided cannulation is very important. If possible, TE guided to check the guide wires and proper positioning of the cannula. Most of the complications during cannulation can be avoided.
So Dr. Sunil Pavani, is there?
Hi, Dr. Mishra.
Yeah, hi. So just a standard question for you. When you start VV ECMO, there are some common problem we face, like frequent chattering, then drop in flow, sometimes hypotension, saturation drops initially, and sometimes there is. So they're the common problem. How quickly you fix them, and how do you fix them?
Flow is very important for establishing. Most of the times this could be related to the blood volume the patient is having. So if there is frequent chartering, that is saying the amount of blood going to the cannulas is not enough. It responds to input of the volume in the form of crystalloids and colloids, minimal crystalloids and more of colloids at this time. And maybe blood would be very useful as well if the hemoglobin content of the patient's blood is low on it. So similarly, drop in the flow, it might manifest later on coagulation problems, including the clotting, is one of the common problems noticed in ECMO. We cannot completely avoid it. To a different degree, they tend to happen. Oxygenator clotting is one of those issues as well. So one has to be very, very careful by watching the pressure drop across from P1 to P2 or trend of the pressures in P1 and P2. That is very important to monitor as well. Hypotension can happen if it is minimal. Inotropes can be made use of, but usually they are flow related as well. It might be an indication that the patient will be needing more of the flow also, especially when it is associated with the next item, which is hypoxia and increasing the lactate also. So more flow will be needed. More flow can be achieved by introduction of additional cannulae. Much more in adult patients, we need to establish in parallel. So oozing from both the cannula side, if it is a surgical side bleeding, then care of the surgical side by applying a ligature would be helpful. Applying pressure would be helpful as well, and replacing the clotting factors.
Great. Okay. So may I go to Dr. Pranay again? Dr. Pranay and Dr. Venkat in together, or Dr. Venkat, anybody can take. The common problem which we face during EV ECMO is persistent hypotension without pulsation. How to handle this? And importance of cardiac monitoring in this situation. And sometimes they have an isolated limb ischemia, particularly high saturation drops 80%. What is the reason behind it? And in late phase, when this persists, this patient develop pulmonary edema due to excessive LVEDP. So all this process, how to sort it out and how to handle. Dr. Pranay and Dr. Venkat, either of you or anyone can take this question.
Persistent. Okay. Oja, you take the persistent hypertension.
See, basically, if the patient on VA ECMO, if a hypotension is there, the reason can be two. One is it can be the cardiac output is low, your ECMO support is low, so you might need to go up on the ECMO support. And second, it can be because of the vasodilatory state, either patient on a vasodilator for a long time, or patient is going into a surge reaction or septic kind of a reaction. So the way of managing them is, first is to improve the ECMO flow, give them the volumes probably that might help to improve the ECMO flow. And second is to, if it's a vasodilatory, then give them the some amount of vasoconstrictor like noradrenaline or vasopressin that can be improve the blood pressure. Also, we have to keep in mind about the pulsatile flow. So that can be, it can be a patient can be going in a cardiac stunning kind of picture. So in that case, you have to maintain some amount of cardiac contractility. So in that case, you might have to use the inodilator. So that might help to improve the cardiac contractility. So everything depends upon how much the flow is we are getting. With the adequate good flow, if the pressures are still low, that means it is a vasodilatory state, and you might have to give some amount of vasoconstrictor. If the flow is not adequate, then you probably have to give the fluid and get the flow up and get the pressures up. And if the flow is okay, good, but the pulsatility is not there, then probably inodilator. So these are the three ways you can manage the blood pressure in patient on VA ECMO.
I would take the cardiac output monitoring. In VA ECMO, the cardiac output monitoring is important for two main conditions. One is cardiac stunning and left heart stasis, left ventricular distension. And secondly is to monitor the Harlequin syndrome. As the VA ECMO progresses, because of deoxygenated blood from the Thebesian vein and the bronchial veins keep on coming into the left ventricle, which is deoxygenated, there is a coronary hypoxia that causes left ventricular distension. The cardiac insult causes left ventricular stunning. Then it causes a raised LVDP, and then raised LVDP causes a pulmonary edema and left heart stasis. So for all these things, cardiac output monitoring by means of TDSA or aortic VTI or raised LVDP or left ventricular ejection fraction calculations, they are of great importance, because as the cardiac output increases, the Harlequin syndrome keeps on progressing. And if the cardiac output is decreasing, then left heart stasis, then left-sided clot starts developing. So the best way of monitoring cardiac output is by hemodynamics and by echocardiography, and of course by radiological appearances. So the daily assessment of echocardiography with other hemodynamic and radiological tools are very important to see that the VA ECMO is not going into complications. You can.
Yes, ma'am.
Of seeing the LV distension he was talking about and seeing the worsening of the MR. And as the MR worsens and the LV dilates further, how some thrombi form in the LV, then back pressure changes in the aorta, and how the aortic valve starts closing. We normally, if we keep trending the echo to do it morning, evening, we don't see the deterioration, or even if we see it, we can take remedial steps. So echo is important, as he said.
Okay, good. So now we continue with ECMO in this patient. Just a quick checklist, Dr. Suresh and Dr. Santosh. Just a quick checklist about Dr. Murli or Dr. Santosh about the BB ECMO and VA ECMO quickly. How do you, when you take round, what you see in VB ECMO patient and what you see in VA ECMO patient to prevent the complication?
Regarding VV ECMO, we are more concerned about recirculation, position of the cannula, and any bleeding at the cannula sites. So we monitor the saturation, and if pre-membrane saturation and the venous saturation is same, then there is more of recirculation and daily X-rays to check the cannula sites. Regarding VA ECMO,
I mean, whatever the ECMO we have something to look common for both of them and something to specific for either of each of them. To look in common, you try to see the patient total. Your patient is, anticoagulation. You try to see how is he neurologically, how is he doing hemodynamically, how are his general parameters, fluid balance. Then coming specific to the ECMO, you look at how are the cannulation sites, whether there is any sign of bleeding anywhere, not just at the cannulation, clinical signs of bleeding in the GI tract or anywhere else. Then do a sequentially thorough examination of the ECMO circuit to see there is no kinks or fibrin strand formation. Check the oxygenated, see the oxygenated related parameters, the delta P over the flows. Any doubt, go for a post-membrane gas to see how our parameters. Look at your anticoagulation. Then coming specifically to the VV, as Dr. Santosh said, you always have the out of cannula misplacement, mislodgement, or a chance of recirculation coming any point of time. If you are looking at VA specifically, you always look for a limb ischemia there. If it is a peripheral percutaneous, you see for the signs of well perfusion in the limb. And simultaneously, you look for a possible North-South syndrome if you are in a peripheral percutaneous. Then you look for a possible LV distension and pulmonary edema. What are all the specific clinical signs for that? If you're having a congested lungs or a pulmonary edema coming there, a distended ventricle on the echo, then you act accordingly. Or you have a desaturation with the right upper limb pulse oximeter or an ABG showing a lower saturation, then you plan and manage it accordingly. Or if you don't have any monitor, if your patient is having a little bit of irritability and all, then you always suspect it to be a possible cause. It's a North-South syndrome, and then take it accordingly. Apart from this, like any other ICU patient who has invasive lines, you should do a thorough look around for a possible sepsis or a possible increase in the infection parameters, and look at all your infection control practices.
Good. Dr. Sunil, on third day in a patient of BB ECMO, if patient started passing lots of urine, around 400, 500 per hour, and then patient sometimes become accelerated hypertension, BP shoots up, and then when saturation, when patient BP shoots up, saturation drops. So how to approach this patient? Excessive amount of urine passing and then accelerated hypertension. There are the two issues which sometimes really creates problem in BB ECMO. How to handle them?
Thank you, Dr. Mishra. Some of the patients are even in general as well. Patients tend to accumulate fluid balance as a cumulative fluid balance. When it is excessive, as the hypoxia settles after going on to ECMO and the renal perfusion improves, patient can start passing this increased amount of urine in the like in this case as 400 to 500 ml of urine per hour. So that could be one of the manifestations of this. Episodic hypertension can be observed, or sometimes it could be persisting as well afterwards. So balancing the sedation is very important. Monitoring the conscious levels of the patient are part of the neuro monitoring process on ECMO. So whenever we lighten up the sedation, patient can wake up and have episodic hypertension also. This can be managed by optimizing the sedation or using antihypertensives. Sometimes there can be a drop in saturation also, but once the blood pressure is optimized and hemoglobin is optimized, and with all the measures we take for correcting hypoxemia and ECMO, such as volume being normal, cardiac that which is an indication of cardiac output, and optimizing the hemoglobin for the patient, these things should be able to be corrected.
Great. What about excessive urine? Anybody like to comment about this? Is one particular problem which we face. Patients start diuresing like crazy on second day, third day, and they diurese, and then things sometimes become really complicated. Anyone who wants to complain? Anybody?
Many times we get natriuresis more. Once we put the patient on ECMO, the probable cause is because the kidneys are usually hypoxic, and the moment you correct the hypoxia, the renal perfusion improves. That is one thing. One thing which we need to always keep in mind is that we had one patient which started diuresing, and the patient didn't become conscious also. So one of the possibilities that I should always keep in mind is about the diabetes insipidus secondary to neurological injury. So that also we have to keep in mind. So these are the points. Plus patient on VA ECMO, usually once the ECMO starts, the renal perfusion improves, so they goes into diuretic phase. So these are the usually we see this is a common. Probably we have to replace the fluid.
Only principle in replacing the fluid you have to remember that you should replace isoosmotic and same amount of the fluid, same constituent of fluid what is passing in urine. Otherwise, it can lead to severe electrolyte imbalance. Yes. So you need to monitor the sodium, potassium in the fluid and chloride, and try to give same amount of replacement what he is passing out.
Thirdly, you can look for recirculation in a hypoxic response because the patient is alert and moving, so recirculation can be there.
Perfect. Bleeding, we have taken care. Pressure drop. Another unique problem: pressure drop and clotting. So how to monitor that and how to prevent that? Because this is another thing which affect the oxygenation as well as life of the filter and how long the ECMO you can continue. So what protocol we follow? We can start with Dr. Venkat, or Dr. Venkat, you can reply on this.
So basically, as the ECMO goes older, the circuit gets more and more fibrinogenic, and clot formation is more. So also the thromboembolic phenomena is more. And the commonest site for clot trapping is the oxygenator. So when there's a oxygenator drop, pressure drop from the pre-oxygenator to post-oxygenator pressure graph, we find as the pressure which was only less than 50, it starts getting to more than 50 delta pressure. That means the obstruction in the tubules is getting more and more, and that is the reason for a drop in pressure. Secondly, the drop in pressure is causing a further drop in cardiac output or the flow in terms of liter per minute. Then it is a need to check for the circuit and maybe a need for change in the oxygenator. So that is the one commonest site. Other possibilities may be a clot at the cannular tip, or maybe a clot in the circuit, which requires a thorough checkup. So there's a protocol for all this circuit check and the blood biochemical test to look at the coagulation and anticoagulation profile. So which would help us to diagnose a clot in the circuit.
Good. Thrombocytopenia, a difficult problem and really complicated. So, what is the protocol for platelet count? How to find the cause for thrombocytopenia? How we can really avoid giving lots of platelet transfusion because we know it is bad. Any importance of monitoring antithrombin 3 and factor 10 activity, and when do you suspect hit? So I liked Dr. Santosh and his team to take this question. Dr. Santosh? And yeah, or Dr. Murli, both of you can take, either of you or both of you can take part.
Thrombocytopenia, that's one of the very common things what we see once we put a patient in ECMO. The causes can be many. To start with, a platelet count has to be monitored regularly for all the patients who are on ECMO on a daily basis. We do daily for all the patients who are on ECMO. So what can be the possible reasons for thrombocytopenia? One, the oxygenator itself can take off the platelets. The second, if you have a sepsis, which can be an underlying, which is brewing in, can lead to a destruction of platelets by leading to thrombocytopenia. Third, a drug-induced thrombocytopenia is also relatively common in these patients. These three are reasonably common. How do you approach and what are the things? In almost all the cases, we try to get a peripheral smear run to get an understanding or an idea of what it is. You look for what is the possible cause there. If you're looking at an oxygenator or a clot formation or a consumptive coagulopathy, which is leading that, you go and look at your how is your anticoagulation, how are the D dimers, how is the fibrinogen faring in this patient, how is the coagulopathy. If it is the oxygenator that is causing all this, then you look at whether you need to up your anticoagulation or if it's an oxygenator change. Then second, sepsis. Whenever you have a clinical doubt that the patient is having an underlying infection, look at the infection-related parameters, procalcitonin and WBC count, and treat your antibiotics. Titrate your antibiotics accordingly. And a third possible causes, if you're on some drugs that can decrease the platelet count, like a ticoplanin, you see that, or a Cetron, if you're for some reason, there you try to take off the offending drug. So this is how you approach for that. In all cases, if you're looking at transfusing the platelets, what is the threshold? Typically, what we follow is less than 20,000 is where we look at a possible transfusion of platelets in these patients. More than 20,000, if you have an active bleeding in the sense active GI bleed somewhere or an cannulation site bleeding, then you can transfuse. More than 50,000, usually we don't transfuse. What we use is using the TEG. We have a TEG in our setup. We use the TEG and see what is the MA in all these cases. If you have a decreased MA, and if you have an associated bleeding, that is where we think of transfusing in these patients. Then monitoring 83 and factor 10A, we don't have, but we get it done from outside. The practical issue, what we see in the factor 10A is that by the time you get the report, it's not like APDT or anything else where your turnover time is short, but it will help you in identifying whether this patient you have coagulated enough or not. Then HIT, when do you suspect? If you have a persistent thrombocytopenia along with a history of previous exposure, or you have crossed that 7 days mark, and you have that other signs where there is a digital ischemia or other signs of ischemia, that is where the hits, you have that hit score, probability score, you calculate that, based on that you suspect. Whenever you have a doubt, you send a hit antibodies and confirm that one.
I would just like to
how to manage.
Yes.
Change to an alternative anticoagulant. We see that shifting to bivalirudin, even if it is not a hit case where the patient's platelets are low, just because of this one, you shift to bivalirudin. You have seen that platelets getting better when you shift to bivalirudin.
I would just like to add here, Rajesh, if I may intervene.
Yeah.
Excellently
Yeah,
said by Murli. You summed it up so well, Dr. Murli. I just want to say that you can use a TEG not just with MA, but also with your lysis. You have lysis 30, LY 30, LY 60. Within 5 minutes, your R time, your CT angle, your MA, your lysis 30 tells you whether it's a hyperfibrinolysis or a hypofibrinogenemia. So if you have low fibrinogen, you know you need to give cryo. If you have a hyperfibrinolysis, maybe a antifibrinolytic agent like tranexamic acid or ECA is enough. If you have a low platelet count with low fibrinogen, then that's the threshold that Murli said, less than 20,000 or less than 40,000 for us, we think of platelet concentrates. So today from the red blood, we have moved into the yellow component therapy, and I'm sure very soon we'll move into the concentrates. We had 3 patients of COVID on Rotem, which I did for some other hospitals. And to my surprise, heparin was the culprit. Heparin causes a lot of thrombocytopenia. So this patient was on low molecular weight heparin, enoxaparin. We continued with enoxaparin and we stopped the heparin for ECMO. It was a VV ECMO for COVID. And to our surprise, the patient today is doing very well. 54th day from NHI, he was discharged. And our surprise is we must know how to have heparin-free or anticoagulation-free periods. That's very important, and when to use the alternative anticoagulant like bivalirudin, like argatroban, or like low molecular weight heparin, for which anti-10A is important. And many laboratories do not do anti-10A in our country. So that's where the lacunae today still is. That's all.
Okay. Another very important issue which we are going to have discuss is one thing: massive pulmonary embolism. There can be two scenarios. One, we have to put somebody on ECMO for massive pulmonary embolism, asystole, cardiac arrest case to revive. And second, when somebody is on ECMO, they develop massive pulmonary embolism. This is also very likely, particularly when they have associated hits. So, how to approach both the case? If I don't know anybody has faced this, and if somebody has faced, they would like to share this experience. Anybody can answer, because I'm not asking any particular. So I want anyone who has faced this and handled, just share their experience. It can be 5 of you, anybody out of the box also.
See.
Yeah, please go ahead.
Yeah, massive. The first one, you're looking at a massive PA as a cause of arrest that you're supporting the patient.
Yeah. And second thing, when you are on ECMO, particularly when there's a hit case, there is a likely that one can develop is continued to have, one can develop P, and how to handle that. So both the scenarios are different. So how to handle the first
scenario, the challenge there is how badly your patient is, or how is your patient anticoagulated. I mean, you're going to look at it like any other eCPR, obviously, how quickly the CPR is initiated, how effective was it, whether it was in the ICU or in the ward, how well it is sustained by the time you're ready to go on ECMO. Second thing that comes more important in this patient is how the pulmonary embolism component handled, how much anticoagulation was given, and whether he was thrombolized, what dose of thrombolysis was given. Because in that situation, if you're doing ECMO, the chance of you having bleeding and cannulation related complications are relatively more. So you have to be having a foolproof technique, or should be done by the person who is most experienced at the point to successfully put the patient on ECMO. Then again, the question comes, even after you successfully have done the ECMO, what is your exit strategy there for the ECMO? Is this such a massive pulmonary embolism that in spite of heparinizing and thrombolizing, the heart or the lung is not going to recover? Then you should look at the other strategies, whether this patient is not need to transfer or something there. So then coming to the second question, a massive PE on a VV ECMO, I have not dealt, but what practically comes to the point is the patient may be going for an RV failure. You may need to support it with a VA ECMO conversion as soon as possible.
Yeah, in fact, we have seen in one patient massive pulmonary embolism, one patient on VV ECMO. Only thing you can do is see, this is not a very common thing because patient is already on heparin, so that this is not a very
rare. Very rare.
So out of 300 plus cases, we are just in one patient. And what you need to do is we have to switch over the patient from VV ECMO to VAV ECMO. So you have to put an additional arterial cannula and convert give a hemodynamic support, also convert into VAV ECMO.
We've had one patient. We have had one patient on VA ECMO where pulmonary thromboendarterectomy was being done. And we came off very beautifully, but beyond that one case, we've not seen more cases of pulmonary embolism with ECMO. So how to put it on an emergency, like Mulli mentioned or Dr. Oja mentioned, or how to do it as a preemptive step so that when you come off bypass, you're not having low cardiac output. I think that's where the differentiation comes in. But it's a good mortality and a good indication coming on.
Very quickly, another fatal complication, air embolism. How do you suspect it and how to manage it? It's a reality. So, Dr. Sunil, would you like to take this question?
Usually, if it is minimal air, it will get trapped within the oxygenator, and that won't create a major problem. But once there is any leading cause for accumulation of air, more and more or massive air embolism, that could result in problems as such. The suspicion is you can see gas bubbles within the circuit, or even alarm can stop as alarm on this detector on the circuit can sound, and it can inform you about possibility of the air embolism as well. The sensors are very, very useful these days as advances are taking place in the circuit design. We can confirm the diagnosis by having a look at it, and we can also hear air embolism or when it is getting accumulated over there. Prevention is the most important part. Make sure there is no crack in the connections or even development of the cavitation within the blood flow. That has to be avoided as well. So all the connections have to be airtight. This should prevent any air getting into the circuit. So the importance is just removing it, as the modern oxygenators are reasonably good, so you can take out the accumulating air. At the same time, one has to look after sustaining it. As for removing the air, we'll be isolating the patient from the circuit. Make sure this air is not entering into the arterial part of the circuit, or the oxygenated part where it is to the patient. So at that time itself, we should clamp, and we should be able to de-air the circuit.
Okay. So very quickly, last question, because I'm just coming to the end of the discussion, and I will be asking Dr. Venkat, how do you handle the weaning failure in VV ECMO, and I will asking Dr. Santosh how he handled the VA ECMO failure. So Dr. Venkat about the VV ECMO, and then his team, and Dr. Santosh about VA ECMO failure and how to manage that.
It's the ECMO weaning failure. So as you have a prerequisite criteria, you have stopping criteria. So if you find that the mixed venous saturation and the PO2 levels are not maintaining as you come down on the flow rates of the FiO2, and the patient starts desaturating, that is a ECMO weaning failure. In weaning failure, because it's a VV ECMO, the pump flow rates are not important. It is only the oxygen saturation. So once you find that saturations are not being maintained, you can step up the ventilator settings to moderate level to assist that the patient can be brought out from ECMO by stepping up the ventilator settings. And if you find the patient is requiring high ventilator support, you have to go back on full VV ECMO flow, wait for the 24 hours or 48 hours, try to correct the underlying condition, and again start the trial of, and then come down to reduced oxygen flows and see if the patient is coming off VV ECMO. So basically, it is just going back on the full flows, waiting for a day or two, and again trying to come down. That is, and trying to correct the underlying condition for the reason of VV ECMO.
And Dr. Murli, about VA ECMO failure?
When we speak about how to approach a failed VA ECMO, we are presuming that this patient, we have put a VA ECMO basically for weaning. It's as a bridge to recovery that we're not talking about a DCM putting a VA ECMO transplant. So when you look at further causes, obviously you would like to see first that the primary problem, what you put the ECMO, has been addressed to a reasonable extent, whether it is just a myocardial stunning or an ischemic cardiomyopathy or some pulmonary embolism, or whatever the reason you have put that is reasonably addressed. How do you practically approach? You go back on your support, give the heart a rest, look for what is the primary problem you have put, and see whether you can do anything to get it better. If it is ischemic cardiomyopathy, whether there is something more that can be perfused, or just the heart needs test, whether you can optimize the inotropes, whether you can optimize your anti-failure medications, whether he needs more diuresis there to venting out the heart and all. So all this you see and try to come off after a certain period of time. In some patients, it may take a week or so. Second time, then if it is not working out, then you look at adding additional supports like an IBP to see whether that helps you in coming off all these patients. If not, if nothing fails second time, and if the heart them on other pathways, that is putting on a temporary LVAD, where you expect that this heart may recover, but this takes a little longer time, like weeks to months, that you can support them on a temporary LVAD. Or by the time, if you decide this patient is not someone whose heart is not going to recover, you put them on the other pathways, that is either a long-term VAD or a transplant pathway.
Thank you, everybody. Thank you for the nice discussion. Thank you, madam, for the opportunity, and
Thank
hope
you,
to see you
Rajesh.
soon. Thank you.
Thank you to
Thank you
all
for
the
that.
panelists and Dr. Rajesh, especially to you for getting everyone together. And like always, complications of ECMO would be immense, but it is the experts which notice it first and then do the needful. Thank you so much.
Thank you.
Thank you, ma'am.
We move on to our next session, which is a talk on ECMO nutrition for ECMO by Dr. Naman Shastri. And I request Dr. Vishwas Malik, who is the academic dean for IACTA for these 2 years, to join us. Dr. Vishwas Malik is a professor in the Department of Cardiac Anesthesia Critical Care. I think he's just finished one session of IACTA, for fellows of IACTA, and he's starting on this. So over to Dr. Vishwas to introduce Dr. Naman, and I apologize to Dr. Naman for waiting. I apologize to Dr. Sunil as well as Dr. Arpan. We are 20 minutes behind schedule. I request all 3 speakers to take 15 minutes each for their talks. Thank you.
So welcome, Dr. Naman. So Dr. Naman is he's an evergreen guy, and he has not aged a bit. He has captured all the E's. He has captured ECHO, he has captured ECMO, and we do understand that ultimately it's the patient who has to heal himself, while we play the role of a facilitator. So nutrition plays the key role in healing, and Dr. Naman Shastri is the right person to speak on nutrition during ECMO. Dr. Naman Shastri, please.
And he works in Epic Hospital, which is another E, Vishwas.
Yeah. Yes, ma'am. Thank you.
Good evening, everyone. Am I audible?
Yes, sir.
Yes.
You are.
Thank you. Thank you, Dr. Poonam. Thank you, TSS, and thanks, Dr. Vishwas, for nice introductions. Being a good friend, always like to hear about you. So just talking about the nutrition during the ECMO. So there will be few learning assessment questions actually. After the end of this session, we should be able to answer is that useful gastric feeding while ECMO, or using the vasoactive in inotrope score is useful? Hello, am I audible?
Yes, you are. Yes, you are.
Hello.
You're audible, sir.
Yeah. Okay. Is there any barriers for adequate feeding on ECMO, or is there any formula do we have for estimating the energies or enteral nutrition formulas, or can we use parenteral nutrition on the ECMO? These are some important questions to be asked. We know that at least 1/4 of the cardiac output is distributed to the splanchnic circulations, and that's account about 30% of the overall oxygen consumption. So we know that gastrointestinal system needs a lot of oxygen, a lot of blood, and when we eat, then the blood flows to splanchnic circulation, which can double up that. So that is something which is known as postprandial hyperemic response. So all these metabolic dearrangement happens in the patients admitted in the critical care unit. The reason being is that these patients has vital organ support are usually unable to meet these requirements, and they generally develop a state of increased metabolic activities. So the catabolism of protein increases, the insulin resistance increases. So this blood circulation, shifting of the blood circulations from the peripheral to splanchnic circulations, and from splanchnic back to the peripheral circulations, all these things is not giving enough time nutrition to the GI systems, and ultimately patients get into the negative nitrogen balance in the body. Now, once patient on the ECMO, the provision of adequate nutrition support is very, very difficult. The reason being is they are highly hemodynamic unstable, and as such they are on the high dose of vasoactive drugs, and that's the reasons why they are on the ECMO. Since there are certain drugs like the steroid and sedative agents are going to the patients, and that also changes the motility of the guts, intestinal normal flora also disturbed. Not only that, if you lose your pulsatility of the circulations, then also affect the intestinal motility. That ultimately results into the gastric emptying is delayed, and the beginning with the enteral nutrition that is delayed, and the calorie protein target is poorly reached. So that's the reasons why even we try to just fulfill the requirements of the nutrition to the patients ever in a enteral feeding, it's very difficult to calculate such. And how much patient needs, it all depends upon the patient's general conditions. When patients are on ECMO and this gastric immotility, the chances of the potential risk of ischemic bowel are very high. There are some evidence in which we can understand that their gastric perfusion is impaired, like the gastric residue volume is more than 500 ml, or abdominal bloating, or abdominal pain, or intra-abdominal pressures are high. At least these are one of the very important they are one of the important signs, like gastric residual volume if aspiration is more than 500 ml is really alarmous, along with the ileus and intra-abdominal wall thickening. So there are the guidelines available for the nutritional therapy patient with the ECMO, but they are for the neonates. So actually we believe that the nutritional management of ECMO patients should be like that what we believe in the critically ill patients. And use of early, so that's what it says, that use of early enteral feeding in first 24 hours to 48 hours of ITU admission should be recommended. That is what we call it in the intensive care unit. When first patient paper presented for the in 24 adult patients having the respiratory failure in trauma, and then ECMO, in the ECMO the enteral nutrition was given, and what it was a conclusion was it was not tolerated well. But in some time, very soon, few personal experiences have been published in literature showing that enteral feeding is possible in ECMO, but it should be always under certain considerations. And supplemental parenteral nutrition can also be tried in such patients. And when significant intolerance to enteral feeding is there, we have to consider that parenteral nutrition can also be given options remain open. So basically, then literally gradually when year passes, the new cases came up into the publications showing that yes, we can definitely give. The reason being is, in a whole big retrospective study with 48 patients, they have found that the mean nutritional goal achieved of only 55% of the nutritional targets in the patient. So half of the patient only achieve the nutritional target when patients are on ECMO. So considering this, the ECMO nutrition plays a very important role. So 50 out of 55 on average, 50% for the VA ECMO, and if 67% for the VV ECMO patients. So usually the patient having the VA ECMO, they are always in highest catabolic state, as well as there is the lowest nutrition and highest nutrition deficit and lowest on the nutritional input. In one of the studies with the patient having the ventricular assist devices and extracorporeal life support, even that studies, the population remains as important, but yet they have proved that still the nutrition aspect is underutilized or under-investigated. In one study, it was found that in VA ECMO patients, when the daily average energy intake is increased by 10% of a target over 8 to 14 days, the 90 days mortality decreased by 18%. Means every week we increase the demand, increase supply by 10%. That would definitely reduces the 3 months day mortality, 90-day mortality. That is a 3-month mortality. So still there is not a clear-cut guidelines that exactly how it should be given, what is an average energy we should calculate, what is the average what is formula we should be using it quite often to supplement the energy. So there are definitely studies have ultimately shown that definitely feeding the patients at the right time in a right way, they can definitely reduces the patient's morbidity and mortality. In a large narrative review of nutrition therapy, out of 31 studies, 12 studies made their criteria, and they have just scrutinized all the studies who had published in favor or against feeding in during the ECMO. And what they found that the early enteral nutrition was related to the decrease in hospital mortality. That was clear. But if you just calculate energy and supply the energy to the patient having the being on ECMO, it does not reduce the hospital supply. So basically, increasing the earliest use of enteral nutrition is a key role that may maintain the gastric flora. Now, out of this, contribution of enteral versus parenteral nutrition was not clear in any of the studies. And enteral nutrition can be recommended in early stages of ECMOs, even when the energy intake from the enteral nutrition is very small. So basically, if we say that the patient, we just initiate the ECMO and immediately starting the patient on the enteral nutrition therapy can definitely be helpful. Now, if you look at the reality, when we place the patient on the ECMO, their hemodynamic severely compromised. Now, since they are hemodynamic compromised, we know that the gastric mucosa and gastric flora is the first organs in the whole body which affects with the hypoperfusion. Decades back, there used to be a gastric tonometry monitoring we used to use to measure that what is the gastric pH and what is the gastric perfusion. So it is clearly evident that it is the first organ to be affected. Now, once we place the patient on the ECMO, then what will happen? It will unload it will use accomplish an oxygenations and hemodynamic unloading, which has direct effect on the VA ECMO, improving blood gases and lowering intrathoracic pressure in the VV supports. So in VA ECMO, it's unload the heart, give the better perfusions to the intestinal gut and flora, and in the VV ECMO, it reduces the intrathoracic pressures. All this provides a better circulatory state by lowering the risk of gastrointestinal hypoperfusion. So basically, when we place the ECMO, then in fact, patients have become more in favor of starting gastric feeding, which was not given before, because that we are reducing many viral pressures, inotropes, and the gastric perfusion is increased. Now, if by giving patients on this feeding, can it adhere? Because we know that in if we use the PK/PD of the certain drugs which can bind to the complete ECMO circuits, like sometimes it is said that it works as a reservoir for the drugs. Should all these components like micro elements, if we are giving to the patients, like vitamins, minerals, lipids, proteins, does it make any difference? So they did one study with the 6 different priming circuits, and then they have taken up the 150 ml begin to like it was in vitro experiments. They have taken the withdrawn the 150 ml, and then after adding the nutrients, they again withdrawn 150 ml after some times. Then they have checked that there was no much significant difference between the 2 different groups, means that there are less chances of the ECMO circuit which can touch or interfere with the nutritional supplements. But of course, there are some evidence which has shown that the vitamin A concentration decrease in both the groups over a time, and there was a decrease in the concentration of the glucose and increase the concentration of the LDH over a period of time, and which was not significant. So how do you assess? Ultimately, once we are very sure now that we should give the nutrition. Now, how do you assess the patients? The first step is to define the degree of malnutrition and assessment of severity of illness, which is very important. This is not once for all. There has to be custom made. Like we have to evaluate the patient's seriousness of illness, his inflammatory state, his metabolic state, patients. How is the patient inflammatory, catabolic, metabolic? All these aspect has to be gone through, and for that we have to assess the patients one with subjective global assessment. In subjective global assessment, we have to go back with the history of a patient. Every patient, when it comes to the ICU, they are not at the same time. Some patient has gone acutely wrong. Some patient deteriorated over a period of time. So we have to distribute them according to classes, whether they are in well-nourished patients, like suppose trauma patients who needs ECMO, they were nourished up till now. The patient who is moderately nourished in cardiovascular group, or patient with severely malnourished. So all these patients has to be categorized. And then we have to evaluate the patient's complete history. We have to measure the dry body weight and all, and the various body mass indexes, All this has to go through before just targeting what patient needs. Now, when we talk about the weight and body mass indexes, and when we talk about the kilograms, kilogram has to be calculated in a dry body weight state. So when we say about body mass index, in terms of anthropometric parameters such as body weight and body mass indices, in retrospective analysis, the ELSO has never suggested that we should ever consider the BMI or nutritional status as a risk factors to be analyzed as compared to the BMIs. Because in 3 centers French ICU studies, they have shown that higher the BMI is better survival. But if you look at the ECMO patient with a VA ECMO, where the patient, like we know that in the higher weight is described as a worsening factor by the survival after the veno-arterial ECMO. So calculations of energy requirements. So now next time comes is So ultimately we have to come with a calculation of energy requirements, which can be estimated like, so once we have decided that yes, patient needs enteral feeding or parenteral nutrition. Number 2, we have to evaluate patients, how much it is required. Now, third thing is can we calculate the energy requirement by indirect calorimetry? But we know in indirect calorimetry, it's very important that we measure the resting energy expenditure. Now, resting energy expenditure is very difficult to measure because human consumption. Where is sound coming? Background, lot of sound noise coming. Some sound is coming from the background.
No, we are all silent here. There is someone speaking in Gujarati there.
Chaudhary needs to be unmuted.
The technique of indirect calorimetry, like resting energy expenditure, is very important. But for the measurement of resting energy expenditure, it is very important that we need to have the oxygen consumption and carbon dioxide. Correct. But we know that when patient is on ECMO, there is a carbon dioxide exhaled through that oxygen, and so we cannot exactly measure the oxygen consumption and carbon dioxide exhalation. So there is one formula which has been suggested for that, which is called Weir equations. This is how they measure this, but it is a very tedious thing, which must be possible only with VA ECMO. With VA ECMO also, this formula doesn't work. So there is no very clear-cut way of measuring the resting energy. So there are some biochemistry studies actually for the metabolic for understanding status, and we need to continuously when patient is on ECMO. Like albumin, prealbumin, total protein, CRP, electrolytes, potassium, chloride, urea nitrogen, creatinine, SCPT, ionized calcium, magnesium, phosphorus, triglycerides, hemoglobin, hematocrites, all these things are very important. Along with that, certain nutritional studies like vitamin C, folic acids, all these studies has to be continuously going on at least 1 week over a period of time, every week to understand, this nutrition studies, and rest of the things can be more frequently we can study to evaluate exactly what is happening to the patients at the micronutrition level. Now, there are different formulas to feed the patient. That is something called semi-elemental formulas or polymeric formulas. Now, the semi-elemental formulas means like we are giving in a very simple form digestive amino acids or amino acid in a very simple form. But the polymeric formula is the one which is a complex form, undigested protein or carbohydrates form. And I think both of the literature has put that both formula are okay to given the patients. The energy goals are usually calculated with the 25 kilocalories per kilogram per day and should be reached over 4 days. Nutritional tolerance is defined as the ratio of effective delivered nutrition to the caloric goal. So if our goal is 25 calories per kilogram per day, then actually how much we are able to give to the patients, in between the difference is called nutrition tolerance. The more than 70% so more than more than 70% of the nutrition tolerance is achieved within the first week. So usually our goal should be at least 20 to 25 kilocalories per kilogram per day. And if patient is having a morbid obese or a BMI is more than 30, then our range should be about 20 to 22 calories per kilogram per day. Now, in general recommendation, daily protein administration to achieve increased protein synthesis and minimize wasting in ill patient is about 1.3 to 1.5 kilogram per kilogram per day, and should be adjusted for each patient individual conditions, whether patient is under stress or patient is in inflammatory conditions. Patient certain conditions like stress, inflammatory conditions may need higher protein intake. If higher amounts are needed for the patients with renal replacement, so in renal replacement patient on renal replacement therapies, so they may go up to the 2 gram per kilogram per day of a protein requirements. Glutamine has proved in many literature, though it is controversial for critically ill patients. But here on ECMO, there is no good studies, but it is said that 0.2 gram to 0.4 gram per kg per day can be tried on the patient having the ECMO. The amount of carbohydrates required is 2 gram per kilogram per day is enough. But of course, when we talk about the carbohydrates, patient needs to be monitored for the sugar control. That is very important. Certain immune-enhancing formula on critically ill patients are conflicting and they are debatable, but fiber-enriched formulas can be well tolerated. And it is said that what if I just explain our own protocol at our own centers, the commercially available certain feeds are there and we give according to the patient's requirements, like whether patient is renal compromise or hepatic compromise, or in certain cases, suppose patient needs high protein with the renal compromise. So they are the naturally available. So we give out of 8 feeds in a day or 10 feeds in a day, we give at least half of the feed with the naturally available formulas. So is there any safety outcome? Yes, hemodynamic stability plays very important role. We just blindly can't follow the feeding to the patients unless patient is hemodynamic well stable. The reason being is when patient is hemodynamic unstable, their gastric motility and their gastric perfusions leads to the distension of the GI system. And particularly the V score is vasoactive inotropic score should be less than 1.4. And that itself suggests that these patients need, if it is more than that, we should hold this feeding. 14 rather, not 1.4, it should be 14. So vasoactive inotropic support, if it is more than 14, it is contraindicated. Use of vasoactive agents, it is very important that certain vasodilators, even the dopamine renal dose, what it is said, it is not harmful, but it is not in a certain higher dose of more than 5 microgram or epinephrine more than 0.1 microgram, or any vasopressure agents added to the patients are always alarming. But vasodilators like milrinone or levo, cimendans, and all drugs has got very low score. So these drugs are not drugs for the contraindications, but particularly the vasopressin, if the dose of the vasopressin has gone above 0.15 microgram per kilogram, it means that this is a very much important contraindications for giving the enteral feeding. So another important aspect is fluid balance. Usually we have the patient having a positive. It is only 1 minute left now.
Okay.
So positive balance, patient sometimes is volume overloaded. So we can add ultrafiltrations to reduce its intestinal edema, and that also can increase the chances of feeding tolerate very well. Patient have fluid, when we have the positive balance and patient had fluid restriction, then that also restrict the nutrition. So all these things leads to the ultrafiltration is the best options when this happen. Patient having the low hematocrit, particularly patient when having heart lung transplants, waiting for heart lung transplant, you cannot give blood transfusion to such patients. So in certain cases, certain hematocrit enhancing agents can be used. But for the positive fluid balance, it is very important that we make patient euvolemic or hypovolemic. Use of prokinetics has been useful for certain kinds, but metoclopramide or erythromycin, which one is better, has not put in comparison, but both can be utilized for increasing the gut motility. And when patient is having the anticoagulations, in such patients may have the gastric erosion and RT aspiration, sometimes we get the stress gastric erosion. In such cases, we have to first manage the anticoagulation, reduce the chances of the gas erosion, and then we just manage. So to the end, it is very important. That we should understand that safe to start enteral feeds early. Safe to start at least vasoactive inotrope score less than 14. If it is more than 14, it is not the best idea to start the enteral feeding. Minimize an NBM status, and it should help in enhancing the nutrition. Indirect calorimetry and blood gases pre and post oxygenator can be utilized to assess the RE, but it is very complicated. The formula is very complicated. The formulas are available. So the question we begin with, gastric feeding while on ECMO is safe to start? Yes, it is safe. Using the V score, when would you hold the feeds? Yes, when the epinephrine is 0.5, 0.15 microgram per kilogram, we should hold it, or the V score is more than 15. Barriers to adequate feeding on the ECMO. Barriers to adequate feeding is ECMO is holds the feed for the procedures or high GRV. In fact, both. Holding the, like for doing any procedures, we also hold it, or the high gastric residual volume. To estimate energy needs while in ECMO, what do? We have the indirect calorimetry added to the VO2 and CO2 from the blood draws pre and post oxygenator. So this is the formula which we are supposed to do. And when feeding patients on ECMO use, it should be any formula, semi-elemental or polymeric, as I said. Either formula can be useful. And using PN while on ECMO is contraindicated. No, it can be useful. Thank you very much.
Thank you, Dr. Naman. Despite your ill health, you managed to give us a very beautiful insight into the Aspen guidelines of 2019 on the use of ECMO in pediatric patients, and summed it up so beautifully according to the Beers protocol that you pointed out to us. Thanks a lot. Early parenteral nutrition and early enteral nutrition, once thought to be hindrances in ECMO, are not anymore so, and that should be the take home from Dr. Naman's message and lecture. Thank you so much, Naman, and thank you, Dr. Vishwas, for a lovely chairing, and I welcome you all to the session tomorrow, 19th. Do join with us on a Zoom link for a hands-on on simulation. I move on to our second last lecture of the day, which is going to be chaired by, I think I'll chair this, Dr. Sunil Povani. Dr. Shambhu has gone and Vishwas had chaired it. Vishwas, would you like to continue with infection control in ECMO by Dr. Sunil Povani? I would like to say a few words on Dr. Sunil. I met him in Hyderabad, then I met him in Bangalore. And whenever I meet him, I feel that pediatricians are the greatest doctors. They are grounded, they are doers, they are thinkers, and they make big of whatever is available to them. And Dr. Sunil Pobani, the founder, president of SWAC also, a very strong backbone of ECMO Society of India, a part of the Caesar trial from Leicester, UK, and now in Abu Dhabi as a director consultant in pediatric intensive care in Abu Dhabi, is a very tall name in ECMO for pediatric patients. So over to him to talk and give us a lecture on infection control in ECMO. It's a very beautiful lecture that he's prepared, keeping the ECMO in mind. Over to you, Dr. Sunil.
Thank you, Dr. Poonam, for the kind introduction.
I apologize for the delay to both the speakers, immense delay.
No worries. It's great listening to you and being associated with you too. From my talk today, I would like to bring up a few of the perspectives, a different way of thinking in antibiotic usage and the way infections function. Antibiotics are very, very important for controlling our cases and making them better. A few of the objectives of my talk today are about infections and then what are the incidence and prevention, antibiotic stewardship, and the dosing of these antibiotics. It's a well-known fact that the bacteria have been living in this world for millions of years, for rather billions of years, whereas we have been living here for 50,000 to 60,000 years, some time period like that. So we cannot expect bacteria who have been living on this planet for so many millions of years to go away all of a sudden or as a result of our antibiotic therapy. So we need to learn how to live together with them. So symbiosis is the way to go forward. Bacteria will get very annoyed if we threaten them with strong antibiotics. They are very clever. They tend to develop resistance pattern with that. So it is like living together in symbiosis as one of the ways to go forward. We have two types of bacteria, the friendly bacteria and the pathogenic bacteria. In fact, the human structure itself is consisting of millions of bacteria as components of the system. So they are not new to us, and we tend to live in a friendly balance with healthy bacteria. But there are again the pathogenic bacteria which we don't want, and we want to get rid of these pathogenic bacteria. I'm sure you heard about this word quorum sensing. Quorum sensing is the way bacteria communicate among themselves. They transfer their plasmids and resistance factors. They exist in the biofilm as well. But quorum sensing is an important way of bacterial language. It is very important to know about this, and it is quite amusing how they communicate among themselves. Yeah, they are so important because they decide the duration of ECMO and they remind us about the need for introspection, the way we practice our ICU care. The infections decide our success or failure, and they're ever so important in our resource-limited countries. So sepsis may be the reason why people may go on to ECMO, and they can be acquired as hospital-acquired infections while they are on ECMO too. Prevention is most important besides attempts to cure them, and the root cause analysis with open mind should be our way to approach these infections. Use effective antibiotics for the right duration, but not for prolonged duration. Prevent fungal infections. Once you prevent bacterial infections, then the fungal infections automatically could be prevented as well. There are certain clinical, besides the clinical behavior of the patient, there are certain markers which are available for us to suspect infection while on ECMO, such as white cell counts, platelets, C-reactive protein, procalcitonin, and blood cultures. Platelets drop at the onset of infection, and this remain drop during the course of infection as well. The recovery of the platelets is also one of the very important markers to tell about improvement in the patient behavior, besides other markers such as procalcitonin. Infections are recorded in ELSO registry data. You can see here various age groups and various types of ECMO, percentage of infections recorded among them, culture positive infections, and those with the white cell count less than 1,500, and the percentage of survival as well. If we take the mean survival in the neonatal venovirus group around 85%, it has dropped to 40% with the onset of infections. So you can notice the impact of infection on reducing the survival of our patients once they are in ECMO. From 2017 onwards, the respiratory runs showing the incidence of viral pneumonia, bacterial pneumonia, pneumocystis pneumonia, aspiration pneumonia, etc. on ELSO registry data is represented here with survival rates also, variable survival rates, but certainly less than what they used to be without infections. Routine cultures from the circuit and from the patient and prophylactic antibiotics are not indicated beyond treating an underlying infection. That is our policy, and that should be the norm as far as possible. Infection among ECMO cases in India, definitely we have seen the incidence of mortality has gone up by 20 to 40% in Indian scenario. Morbidity, ECMO duration will increase by minimum of 1 week to 10 days when they acquire infection, and drug-resistant flora will develop with their effects on antimicrobial failure also. So this we have documented nearly 3-4 years ago from the Indian data. Common infections are gram-negative infections these days, followed by gram-positive, then fungi. Multi-drug resistant strains are very well known in our atmosphere, and the viruses are also predominantly resulting in infections initially, later on adding bacteria and fungi. The risk factors for sepsis, while an ECMO are ventilator-associated pneumonias, bloodstream-associated infections, and catheter. Most importantly, the incidence of infection will be with the ICU, the protocols we follow on them, and the antibiotics prescription practices being followed on different ICUs. What I mean to say is a surgical ICU is different from medical ICU, is different from pediatric ICU or neonatal ICU. It all depends on the practices we follow on these ICUs. There are certain reports available in the international journals about the infections acquired by adults on ECMO. Adult patients who underwent ECMO are at a greater risk for developing nosocomial infection and sepsis than neonates and children. 20.5% of adults versus 6.1% of neonates and pediatric patients developed culture-proven infection in this study from Australia. The incidence of infections as well, gram negatives are the commonest, followed by gram positives. And again, the time duration on ECMO is an important factor, which has a direct proportionate relationship to the possibility of acquiring a serious infection while on ECMO. Here you can see those on ECMO for more than 12 days have developed and had more chances of developing infection while on ECMO compared to the ones who spent less than a week. During ECMO, the prevalence of hospital-acquired infections is around 10 to 12% from this study by Stephanie Biffy et al. And high incidence of ventilator-associated pneumonia was reported. Again, high rates of invasive fungal infection was noticed in COVID-19 patients on ECMO from this study. There were invasive aspergillosis and invasive candidiasis, both. So they have to be paid attention to, especially if there is any antibiotic abuse, then the fungi tend to grow more and more. In COVID-19, another report on COVID-19 associated fungal infection during ECMO published in Contagion, like for the fungal infections as for the mycology consensus criteria, voriconazole or isoconazole are recommended as the first line, and echinocandin is the recommended first line therapy for Candida associated bloodstream infections. Coming to the basic factors, washing hands is extremely important. As William Osler mentioned a few centuries ago, soap, water, and common sense are the best antibiotics. Probably alcohol with chlorhexidine is the best antibiotic solution that we can use, but there are other combinations available too. Few years ago, in 2009 to 2011, that time we were blamed for the isolation of New Delhi strain of drug-resistant bacteria, NDM strains, though they exist worldwide, as they were isolated for the first instance in Delhi, we were blamed for that. Anyway, these are the drug-resistant bacteria, and it has been shown that these bacteria do exist in water as well. The drinking water sample showing drug-resistant bacteria in the country. So to clear these bacteria, tap water has to undergo reverse osmosis process. That is the only way we can get rid of these bacteria. Not only that, it is a well-known fact that Pseudomonas and other bacteria are commonly associated with water supply. So one has to pay attention to that as well. The other important factors are the active ingredient of the drug we are using. This I just want to make a mention, like we have different brands of medicines available. Say for example, colistin. It is available for 800 rupees per vial versus 6,000 rupees per vial as well. Which medicine among these has most of the active ingredient and which one has got less? So I leave it to your judgment to think about it. The drug levels are important too. Hepatotoxicity, nephrotoxicity of these medicines have to be paid attention to. One of the most important factors regarding the management is do not use the antibiotics forever. Use them for the duration required, and after that, please de-escalate by careful watch. If other infection comes in, we are very welcome to antibiotics as per the protocol. We evaluate them again, but it is not ideal to continue antibiotics forever. Certainly, there were times when we spend times on ECMO without antibiotics being on. So it is a myth that antibiotics should be on all the time. First of all, we have to improve our ICU microenvironment. Once it is done and the bacterial contamination or transmission of the bacteria on the ICUs to the patient, it comes down, then we can certainly practice these measures such as de-escalation of the antibiotic therapy and also keeping running ECMO patients without antibiotic therapy when they don't have active infection. Fungal prophylaxis will be needed at times as well. In neonatal practice, sometimes this used to happen and this might continue to happen as well. If a drug such as colistin is made up, people tend to use it till it is exhausted for a 4 days, 5 days period like that. As their blood volumes are quite small, they tend to have one vial lasting for longer duration. But the efficacy of the medicine will not last for that long once it is reconstituted. These are simple things, but worth paying attention to. Please do not allow any of the staff members to touch your patient without cleaning their hands and using a hand rub. Empower your nurses to make sure this is fulfilled. These are very small things, but they are very important in avoiding transmission of infections to the patients. At the Krishna Institute of Medical Sciences, we were using simple measures like keeping central lines within a sterile gauze piece like that. At least it gives the notion for the medical team like this is not the right one to approach for each and every time. Each and every time you want to give a medication or draw blood sample, you shouldn't go for the central line. So it gives that notion that there is something precious there and keeps us away from those infections. Some simple things such as using ultrasound probes for doing an echocardiogram or ultrasound page on these patients. We tend to use the probes. We don't sterilize them with any antiseptic as we shouldn't and keep them back again after the routine procedures. These things can transmit infections from patient to patient. If we use a glove with just an ordinary glove with some gel inside and use it as a probe cover, that will certainly help in preventing infections being passed on from patient to patient. You can throw off the glove after examination. Some of the surfaces like this, which are touched upon many a times for the nursing practice, we tend to sterilize them or clean them once in every shift as the nurse comes in. I found these plastic aprons to be very, very useful in avoiding transmission to the patients. Intentionally or unintentionally, we tend to touch patient microenvironment onto the bed very frequently. So whoever examines the patient should wear the plastic apron, which costs 1 to 2 rupees only. Again, the gloves, wearing the gloves for examination of the patient are very useful, and it has been found that 25% of the infection rate has been cut down by using the simple gloves for examination of the patients. So looking at this patient, surgeon has done uh, dressing here and left the material over here unintentionally, but you can see this area has been contaminated, and once anyone else from the medical team goes and touches the surface, then they will acquire those bacteria from there. So simple things like that have to be looked at. Rethink the ways we are functioning with respect to preventing infection in our country. Modification of our behavior is the way to go forward, and physicians' will is the most important determinant in treating infection and avoiding antibiotic abuse, preventing resistant organisms to grow further and further. So that is a principal basis for the antibiotic stewardship program. It has a role to play in ECMO practice as well, and commitment to all the principles of antibiotic stewardship program are very important in preventing infections on ECMO. Antibiotics and the doses about it, broad spectrum antibiotics as decided flora on the unit start initially, de-escalate and modify the antibiotics as per the culture and differentiate between the commensals and pathogens. Narrow spectrum antibiotics can be used for the right period of time. Appropriate dose of antibiotics is important as well. There are certain antimicrobial surfaces like copper. If people can use them, copper coated surfaces are known to kill bacteria and viruses to an extent of 99% in an hour or two. We use the interventions as a bundle, but no blame culture is extremely important in preventing these infections. My last couple of slides show importance of staff education, specify the staff for duties and responsibilities. Education is a matter of continuity, train under the senior's observation, and train the staff with scientific goals. Review our situation openly, understand the lacunae, tighten the loopholes, and further advances are very much necessary. Implementation is important. Everyone in the team are important, more so are the sweepers and cleaners and the unit too. With their dedicated cleaning practices on the unit, we tend to keep our antibiotic aseptic precautions and our antibiotic stewardship programs alive. So we should be indebted to each and every member of the team. To me, standing in a corner of the ICU and observing the behavior of various colleagues, what they are doing, tells a lot about what are the factors to be focused upon when we are paying attention to infections. So the take-home message is to a simple principle such as routine and effective hand hygiene, and paying attention to the microenvironment we are caring for our patients, changing the way we do things, antibiotic de-escalation when they are not needed, no blame culture, and examining the cost effectiveness of our interventions is very important. Use interventions as bundles. This is my last slide. If I say, yeah, we all know, we all work in theaters, we know that the most aseptic environment. If you believe that, why don't we maintain our ICU patients in such an aseptic environment as well? Think about it. I leave it to your wisdom. Thank you very much. If there are any questions, I'm happy to answer.
ICU. That is really food for thought. And every member of the team matters, every member. I totally agree with you. And education of the team on nitty-gritties matters the most. Thank you so much. Any questions to Dr. Sunil Pubani? He'll be happy to take one question. Anyone? Well, if there are no questions, thank you so much, Dr. Sunil. From here, from all of us, we'll meet soon again for an ECMO conference. You told us good about infection control in ECMO, and I'm sure each one of us will have a take-home message on that. Thanks a lot. Thank you.
Thanks a lot, Dr. Poonam.
Bye. Bye. We come on to the last lecture of the day by the man who is the COVID ECMO man. And thank you, Dr. Arpan Chakravarti, for your patient waiting. And thank you for agreeing to do it in your busy schedule. He should be congratulated today for having done a very successful ECMO in a patient of pancreatitis. So new indications for ECMO are on the horizon and everyone is working hard to strive for it. Dr. Arpan is a consultant intensivist and ECMO training senior consultant at the Medica Super Speciality Hospital, Calcutta. With 20 publications to his name, he is a big name with his team of Dr. Dipanjan and others from Super Speciality Medica Hospital, Calcutta, during the times of ECMO COVID-19. I think their work probably in the country has been stupendously exemplary. And no one better than him to tell us about ECMO and COVID-19. But before I do that, I want to also talk about Dr. Suruchi Hasija as well as Dr. Arindam Chaudhary. My two consultants about to be senior professors now from AIIMS Department of Cardiac Anesthesia. Dr. Suruchi Hasija is an additional professor at Cardiac Anesthesia Critical Care, a DM. Both of them are from our department itself doing great work in COVID-19. And I want both of them to talk about AIIMS experience in 2-3 sentences each about COVID-19 and our department in particular. Over to Suruchi as well as Arindam Chaudhary.
Thank you, ma'am, for the kind introduction. So, ma'am has already introduced Dr. Arpan, and Dr. Arindam will add further details to his introduction. But given his topic and the pandemic that we have faced in the last 2 years, we will now see from Dr. Arpan's experience how ECMO is different in COVID patients. How is it different given the common pathophysiology of COVID and heparin-induced thrombocytopenia, and given the constraints of the personal protection equipment, how it behaves differently in COVID patients. From his vast, enormous experience, I'd like to learn more from you, Dr. Arpan. But before that, Dr. Arindam, please add to your kind introduction, please.
Okay, thank you, ma'am, and thank you, Suruchi, for giving me the space. I just wanted to tell that like COVID-19 was an unprecedented situation, and every system's usefulness and robustness is tested by when you apply the stressors. So when you talk of ECMO and the system of care of ECMO, so COVID-19 was a perfect example of a stressor which has ultimately given the ultimate test to our like development so far of ECMO. So also Dr. Arpan is one of the dynamic person and a very I would say who calls it a spade, and he is a person who describes himself as an oxygen delivery man. So let us hear what was his experience of this pandemic and managing patients with ECMO support, and let's hear from the oxygen delivery man. Welcome, Dr. Arpan.
That is very nice.
Thank you. You have reduced my one slide. So,
welcome, Arpan.
Yeah. Whenever I speak something on ECMO, I'm just a spokesperson of my team. You cannot perform an ECMO without a team, and COVID-19 ECMO is require a bigger team. So I'm just a spokesperson of my team. And we all know that Madam told we have started ECMO in 2014.
and slowly it became popular with Madam Jayalalitha's in 2016, and followed by the COVID. And this was my team. And this is our center in the ECMO center availability map published by ELSO in 2020 for the COVID itself, and center number 738. And to start with, ELSO tells us when to give ECMO in COVID. That is written in the ELSO website. It's a PO2 ratio is less than 100. It is not 60. Oxygenation index more than 30. MARA score more than 3. It's normally with other ARDS. And the contraindications are, no absolute contraindication has been given the first line. Relative, obviously, with the mechanical ventilation more than 7 days, which we violated like anything in this part of the COVID. Major pharmacological immunosuppressions, again, we have violated. We have put ECMOs in, obviously not in febrile neutropenia, but immunosuppressions, on immunosuppression, we have put the patient on ECMO. Non-recoverable comorbidity and major CNS damage and terminal malignancy, that has been obviously given some importance. And patients in gross multi-organ failure, we have avoided, but many times we landed up in doing that. ECPR, we have categorically not used in COVID, and we have started slowly after COVID. And conversion to VA ECMO from VV, mostly it was 95% VV ECMO, and conversion to VA ECMO is probably the potential hemodynamic derangement from hypoxia, myocarditis, and the RV failure was the main cause of going to VA ECMO. And any condition refractory hypoxia, many times we had to put in VA ECMO, but not in our place. I just will start with a case. He was a 44-year-old guy. He had a very long history, 1.5 months in a hospital. Then he got intubated and shifted to our hospital as after putting it on ECMO there. And they told him to go for lung transplant because he had already 1.5 months passed of his disease. So he didn't deny for the lung transplant, and he came to us after that, and he was diagnosed with the CMV pneumonia along with the COVID. And the CMV detected more than 1 lakh copies in the blood. I have not seen that number. I have asked various people, they have not seen also that much of CMV, more than 1 lakh copies. And associated with, he had acute CMV myocarditis. Initial ECMO run was very uneventful. He was improving lung X-ray, lung compliance, chest X-ray. Everything was improving for a month. From mid-July, after a month of ECMO, he started again worsening the X-ray. The X-ray from, you can see the mid-July X-ray, he started getting again down on ECMO. And in front of me, he got a cardiac arrest during a round with this kind of LV. If you can see the video, LV, severe LV dysfunction, probably because of CME myocarditis after a month on ECMO in front of me. And we actually put the patient another arterial cannula and take the patient on VAV ECMO after a month of VV ECMO. VAV ECMO started doing well. He got stabilized. After VAV, after 10 days of VAV, his ejection improved. His function started improving from 10% to 20%, 30%. And we could take out the VA ECMO again and continued on VV ECMO because lung was not improved again in the month of August. After 10 days of VA ECMO, VAV ECMO, we took it to VV ECMO. And from that time, he got a sustained improvement. And on September, after a month again, we could successfully come off all forms of ECMO for him. That was the X-ray where we came out of ECMO. And he got discharged after almost 90 days of ECMO with 4 months of hospital stay. And this is the X-ray after 4 months of follow-up with a good improvement in the CT scan also. So with that thing, I can tell you this paper cutting came out in 2020 July, where they have told this 43% of the COVID-19 deaths in India is between 30 to 59 years of age band. That means we have lost many of young lives who are actually the breadwinners of the family. At that point of time, we have not used ECMO because of the lack of availability of the systems, lack of availability of the oxygenators, the consumables. And what was the treatment of the critical COVID at that time, only oxygen, good critical care, and low molecular heparin, low dose steroids, which was established after recovery trial. And those three things, immunomodulator, plasma, and antivirals, came as a big setback that was not helping. So with only oxygen and some bit of steroid was the main stay of therapy with the low molecular heparin, with a good critical care setup. And with that thing, we contributed a interim guidelines from ELSO and with the consensus documents how to put the patients in COVID-19 on ECMO. I was a contributor of that. And the current challenges, that point of time was the pandemic, the manpower, the resources, the finance, and the initial outcome bad reports from the Chinese study, which shows more than 90% outcome, bad outcome in the run of ECMO initially in the COVID. And obviously the staff safety, which was before the initiation of the vaccine, which came in the probably during the second wave. So with these things, ECMO become a different in COVID ECMO, become a different from the, even in our center where we have started ECMO in 2014, we found a bit of difficult because all resource and techniques utilization before ECMO, we have to prone, we have to give a lot of non-invasive things, we have to give the ventilator, then to take the patients on ECMO. Not all of the patients you can take on ECMO. ECMO is done in a cohorted place, which is not in the CTVS ITU. It has been done in a different place, which is probably a COVID ITU. Utmost staff safety, that is most important. Remote monitoring, you can't enter always in the ICU, so you have a camera or EICU facilities. Careful is bronchoscopy and tracheostomy, aerosol generating procedures, handling of the membranes properly. Decannulation is as important as the cannulation because that can lead to the problems. Ethics, plan for futility, which patient you will give, which patient will not sustain. Any multi-organ failure, you have to take out the ECMO, wait for the waiting next 30-year-old who can improve on this. And the thing is, no relatives are around. You have to go for a video call or you have to go for a audio call, whatever it may be, but no relatives are allowed. Either they're sick or they're in the quarantine. And obviously, the pathophysiology itself, ECMO in COVID, led to more number of thrombosis, prolonged and protracted course, early multi-organ dysfunction syndrome, because COVID is an endotheliopathy. It doesn't only involve the lung, it involves all over the body, and the cytokine storm, which is the most killing part. And the slide you have told me that why we have started this ECMO, because ECMO is basically an oxygen delivery, tool of oxygen delivery, and it saves from the acute decompensated hypoxia, even on ventilators in the patients. And this was our thing. We put 153 ECMOs in 2 waves and 98 cases of femorojugular, 55 cases of femoral, 6 was VAV. We came out ECMO from about 63 patients. It was 40%. The initial first wave, it was more than 45%. The second wave, we suffered. It came down to less than 35%. And the overall outcome came out to be around 40%. And if you see, this is the ECMO ICU. When you ran an ECMO, more than 30 ECMOs at a time in the peak of the second wave, all the patients are on ECMO in an ITU. There are 3 ITUs in our hospital, which are all the patients are on ECMO. The different systems, somewhere in Centrimac, somewhere in your Mackay machine, somewhere in Soreen, whatever we got and whatever things we get, we put them on ECMO. And to at least they will not die because of the oxygen deficiency at that point of time. Now, looking at our 130 cases, we have analyzed ventilation to ECMO was 52 hours. Mean PF ratio we have put on ECMO is 0.65. Proning, 75% of our patients on ECMO proned before ECMO. Renal replacement therapy is 30% almost. Myocarditis, which was prevalent in the first wave, much more, the 12%. Shock lever, we got 22%. Cerebral issues, COVID encephalopathy, which is a late 15%. Circuit thrombosis, very fortunate we are that we had only 5 cases of circuit thrombosis, other than the regular circuit changes. And cytokine storm, which is the most lethal part, had happened almost 25% cases of all deceased things. And this is the cytokine storm patients, the COVID-19 ECMO with cytokine storm. I know we had a different discussion with the cytosol, but this cytosol we have used in 20 patients, but they didn't give good results. I have used cytosol in 20 patients in COVID ECMO, and out of that, only 4 went home. And cytosol helped them at that point of time. We have connected the cytosol in the dialysis or as a dialysis machine, and we took it, run for 12 hours each. This is another challenge we faced. Obese patient who are more than, right one is the 150 kg, the left one is 160 kg, and they could not be prone, and because of logistics, and we put the patient on ECMO. The right one, right guy has improved. He went home. The left one didn't improve, and he succumbed. So obesity, extreme obesities, if you can't prone, ECMO might be beneficial at that point of time if you put them on early. He was also a 120 kg man. He came with a 9% saturation from a different hospital. We immediately put the patient on ECMO, and he revived after that. Another thing we learned in this COVID, that proning, whenever on ECMO, your lung is not able to generate a saturation of more than 85% or more than 90%, even with full ECMO, full sedation and all these things, you might need to increase the lung contribution by proning the patients. And we proned regularly these patients on ECMO. And many a times after proning, after the lung recruitment, the saturation came up. The prone ECMO study is going on. It is still recruiting, and the result will be out in 2024. This is another one. I told you the pneumonia with myocarditis. It has happened mostly in the first wave. The myocarditis itself causes a lot of issues. And if you see the bigger hearts, and the myocarditis improved after many a times after that, and slowly the lung improved after that. This is another one, the 5th ECMO inserted after 5th proning. That means late referrals. I told you the contraindications were more than 7 days, but we had to put the ECMOs even after 21 days. They've got late referrals. The young patients, still recoverable lung, we have put the things. And with the late referrals, the complications were also higher. This patient, we put after 5th proning, almost 12th day, and we lost him due to massive ICH because of the fluctuations in the carbon dioxide level, probably. This is another thing, COVID encephalopathy, 107 kg pneumonia with ARF. I was put on ECMO. He improved, but because of the encephalopathy, he took a lot of time to come out of this ICU even after coming out of ECMO. Air transport, we have done a lot of air transport and ground transport to bring the patients from different part of the mainly in the second wave. With the first wave, nobody was transporting in the air. Decannulation is as important as cannulation. We have to be properly in your girds to take the cannulas out even. This is another thing you have to ask, that prolonged ECMO is more than 30 days. This is the hallmark in our series in COVID. Ehrlich syndromes are basically more prone to prolonged ECMO. If you have pneumomediastinum, if you have pneumothorax, you have to have a surgical emphysema, they are more prone to prolonged ECMO. And the CO2 clearance is the main issue, is the latter part of the ECMO run than the oxygenation corrected first. And very low heparin requirement in such long run. Many times we have run the low heparin free ECMO because of the associated thrombocytopenia because of the long ECMO run. And for the prolonged ECMO, a lot of things we have done. This is a patient where we are fooding on ECMO. He's eating, his lungs not yet improved, but he is having food on his own. So this is the way we ran our longer ECMOs and made them at least psychologically, and your muscles are not let it weak so that you can come out. Mobilization of ECMO, she was with us for a day till day 48 of ECMO. She came out, she was a dentist, and she was sitting on ECMO on the chair and doing well after that. And this is the way we patients are mobilized on the chair on prolonged ECMOs. And this is the thing we have taken from Amazon to use for the lower limb weaknesses on ECMO. And we have used it to improve the lower limb muscles on patients on ECMO. You have to be careful for the dislodgement of the cannulas, but you can do it under your supervision. And if you see, he was our colleague. He was our colleague. He got infected before the COVID vaccine came out, and he was on ECMO for 14 days. And we made him sit at the edge of the bed. And after going home, he has sent this picture to me after 2 days that I'm doing fine and I can join back to your army. This thing. So that much of spirit was there. And he came back, he took vaccine, and he's doing fine till now. And this is the thing which is nevertheless should be told, the post-ECMO follow-up clinic. The survivors are the main proponents of this ECMO program. They are for them, we are surviving. So you have to take care of your survivors for the thromboprophylaxis, for the residual lung function and psychological boosting, and assist them for the professional comeback. He's Somnath, he's 38 days of ECMO. He has sent this picture after going home that he's doing a good physiotherapy and he's doing fine. She was a pregnant patient. She was with us for 81 days of ECMO, and she recovered after that. So a lot of prolonged ECMOs have came out in this during this COVID. Obviously, the infection is a great hindrance, but they came out in spite of that. And all the doctors, all the medical fraternities that ECMO helped, in this picture, all their doctors, and they show their gratitude to us, to ECMO, that they came out during their during this COVID. They got infected during their practice, and they're doing well. She is my college senior. She's a neurosurgeon. She got infected. She rushed to us, and she was there with us 25 days. And she was a critically acclaimed tribal photographer with a neurosurgery, and she is doing well. So this is the experience I have shared with you. Thank you, madam. Over to you.
I think it was your dedication, your team's dedication, your passion and your knowledge expertise that brought about such positive results. You had one today also. I congratulate you for your pancreatitis patient. I just read about it. The entire team has done a very focused job, and focus comes from dedication. So congratulations to the whole team of Dr. Kunal Sarkar, Dr. Arpan and Dr. Dipanjan. All the best to you. With COVID came the knowledge of ECMO, and with COVID came the knowledge of Zoom and webinars. We end this Zoom and webinars, which has connected many surgeons, anesthesiologists, intensivists, pediatricians, and many students and mentors across India, and I'm sure outside India also. We have the YouTube link ready with us, and it will be displayed soon. On the chat box, soon after I end, you'll have the YouTube link to you. And those of you who connected with us, we'll have the YouTube link sent to you. So thank you so much. We have a hands-on ECMO simulation session from the AIMS Simulation Education Technical Committee tomorrow. And it begins at sharp 8:30 and it finishes by 3:30, 3:45. So everything about ECMO, please join us. Whatever you heard today from the experts, come and see for yourself on the mannequins, practice the cannulation, practice any troubleshooting, and see for yourself how we do better, just as the way Dr. Arpan and their team have done. All the best, and thank you to all the speakers. Thank you to the ECMO Society of India mentors and founders. And thank you to my department, the Department of Cardiac Anesthesia Critical Care, led by Dr. Sandeep Chauhan and followed by 9 of us. We are a small department, but we are also focused, but maybe in another era, learning to pave our way to success. Thank you so much. Thank you all. I thank the CMET team for their dedication at AIMS and my TSS office team for always being there for all webinars, big and small. Thanks a lot. Thank you, Arpan. Thank you, Arindam, and thank you, Suruchi, for chairing this session so beautifully in a conjoined way. Thanks a lot. Thank you.